Good evening, everyone, and welcome to the South Karnataka Conference on Fetal CNS. Today's topic, in fact, is a highly specialized one, but I would say is a perfect amalgamation of all the specialties that needs to be included when it comes to diagnosing and prognosticating a fetal anomaly. And in our endeavor to reach Pan India, the Society of Fetal Medicine probably is doing the first ever webinar with the faculty of South Karnataka. And the credit for this conference should go to Dr. Akhila Vasudeva. She has been instrumental in getting all the faculty together, and I'm sure this is going to be a mesmerizing webinar. And it's a very highly specialized one, so looking forward to it. So we begin with the first lecture by Dr. Akhila. She's going to talk on approach to ventriculomegaly. Now, Dr. Akhila is a very renowned fetal medicine specialist in Mangalore. She is the head of unit in OB-GYNEC, but she is the chief of fetal medicine unit in Kastuba Medical College, Mangalore. She has been instrumental in undergraduate as well as postgraduate training programs, and she is the backbone of today's event. So over to you, Dr. Akhila.
Hello, good evening, everyone. First of all, thank Dr. Ashok Khurana, thank Dr. Mohit Shah for giving me this opportunity. I hope we do a justice to it as a team. So without wasting much time, I would straight away go to my topic, that is approach to ventriculomegaly. I will share my screen now. So I hope everyone can see my slides. So before So first of all, this whole talk is on not on ventriculomegaly, not on the theory of ventriculomegaly, not on the etiology of ventriculomegaly. It is on approach to ventriculomegaly, meaning when you get a case of ventriculomegaly, how do you solve the problem? So that is the whole topic of today's lecture. Another 15 to 20 minutes, I'll take you through this ventricular system. So before understanding ventriculomegaly, all of us, let's remember our undergraduate knowledge. CSF flows through from the lateral ventricle through the foramen of Monro, it goes to third ventricle, and then through the aqueduct of Sylvius, it goes to fourth ventricle, and then foramen of Lashka and Majetti, it goes to the subarachnoid space of spinal canal. So first of all, when we understand this, how do we define ventriculomegaly? When you say ventriculomegaly, you usually mention that to the lateral ventricle. So you diagnose ventriculomegaly when the width or the transverse dimension of atrium of lateral ventricle is 10 millimeters or more in the second and third trimester. So each part of this definition is important. It is a relatively common referral to fetal medicine unit. Almost every week, I think we have several cases of ventriculomegaly referred to us. It is classified as mild, moderate, and severe. In many of the publications, they club this mild and moderate together as mild. The reason being the etiology, the diagnosis, prognosis, and outcome of moderate ventriculomegaly, that is 13 to 15 mm, is closer to the mild rather than to the severe. So in some publications, they club that, but in this lecture, I'll keep them separate. Why do we measure the atrium? Atrium is the first area to dilate. It dilates to a greater extent compared to other places of lateral ventricle, and the measurements remain stable in the second and third trimester. Moreover, in the usual transaxial planes that we take for transthalamic transventricular planes, it is readily identifiable, and being perpendicular to the ultrasound beam, it is easily measurable. ICO and other international authorities have laid down clear guidelines how to measure this atrium. It's very important to follow these guidelines because small difference in your technique can result in lot of false positive and lot of false negative results. In fact, many of these referrals who come to us as borderline ventriculomegaly, they're normal ventricles. So there is a substantial intra and intra-observer variability. So we should be as perfect as possible in this measurement. And remember, when the atrial measurement reaches 10 millimeters, you're already 2.5 to 4 SDs above the mean. So don't use all these subjective findings for diagnosing ventriculomegaly, because these subjective findings should only increase your suspicion, but ventriculomegaly should be diagnosed as per the standard guidelines. We should not get confused between these two words. Hydrocephalus is different from ventriculomegaly. When you say hydrocephalus, there is a altered CSF dynamics. Most commonly due to obstruction, it may also be due to increased production. But when we commonly say ventriculomegaly, ventricles are mild to moderately enlarged from non-obstructive causes. Of course, severe ventriculomegaly may be due to obstructive cause. It may mean hydrocephalus, but these two words should not be used interchangeably, because ventriculomegaly is not always associated with altered CSF dynamics. At the same time, there are many other reasons for cystic areas in the cranium. This subject will be dealt by Dr. Gauri, and we should not measure all those cystic areas and say it is ventriculomegaly. Remember, ventriculomegaly is not a diagnosis, it's only a symptom like fever. So when somebody comes to you with fever, you try to look for the reason for fever. So it only ventriculomegaly should prompt further investigation to make a final diagnosis. There are heterogeneous, multiple etiologies, wide range of neurodevelopmental outcomes based on these etiologies. Therefore, you need a systematic problem-solving approach to reach a possible differential diagnosis. Now, this approach, I am
I think we have a small technical glitch, but I do hope we should be able to have Doctor back in a few seconds. Some of you might have also faced a glitch, but I think most of us are still pretty much here. And I am hoping that we should have this talk restored in a few minutes. Do bear with us. It has been a really fantastic approach that we've made here in the meeting for you today. And I truly thank Dr. Akila for putting this together. It's a very niche topic, and I'm still thrilled that we have almost 200 people participating here right at the beginning of the program. We do hope to have much more as we go along. And hopefully we will manage the access for you in a few minutes. See us and hear us, I request you to keep your video on, but keep yourself muted so we know how we are connecting up with everybody. Very nice. So I think we should have Dr. Akila back in a few minutes. And we know that there was a bit of a glitch at her end, but we have reconnected this, so I think it should be all right. And I'm truly looking forward to this very, very detailed program. It's so nice that so many of us have been able to make it right in the middle of the week. We've had a fairly crazy week in Delhi, but I'm glad that this trouble didn't spread to other parts. But this is nice. What we are going to go through this evening is a very, very interesting approach to fetal neurology. We know that every day we get changes. Every single day we read something new in the literature. Every day we realize that there is just so much to learn from this. We do realize that concepts are changing. The concepts of measuring the lateral ventricles changed a few years ago, and there is a possibility that we will have another change coming up by halfway through this year. Apart from that, we realize that genetics has made tremendous progress. But most of all, and central to all of this, is that we have realized the importance of teamwork. And we have realized that each one of us with our specialties is a cog. And so we should be able to perform that role. Not very easy because it involves good imaging, it involves access to genetics, it involves a wider understanding. And with literature becoming so expensive, we're trying to see if we can possibly arrange through the Society of Fetal Medicine distribution of this literature. And more of that as we move on in our program. I think everybody's back on again. Dr. Akila, are you able to?
Yes. I'm going to restart.
Wonderful. So can we start from the beginning? Because I think some people got interrupted halfway through.
Yes. Just give me a moment. I'm so sorry for this.
Not to worry.
Just give me a moment.
There is no rush at all. And so I was telling the audience on how, because access to literature has become so expensive, we do feel that it might be a very good idea to share literature after taking due permission, which the society will take on behalf of all its members. So that will make literature access much more easy for most of our members. It's a plan we have for this year, and let's see how it works out. Dr. Akhil, are you comfortable with the screen share as yet? Or?
Yeah. I'm going to do that.
Ah, wonderful. If any one of you is unable to access this, please let us know in the chat box so that we can organize this. We might then just shift part of this onto YouTube or Facebook. But so far, I think we're in order, and there we are all set to go again. Wonderful. All yours, Dr. Akhila. Let's start from the beginning so that.
All right. I hope I'm audible. So I will just go on to the definition part first of all. So it's so important to follow these guidelines to measure the atrium of the lateral ventricle, because very small differences in your technique can result in false positive and false negative results. And there is a substantial intra and intra-observer variability, particularly many cases referred to as borderline ventriculomegaly are actually not ventriculomegaly at all. When you reach 10 millimeters, you're already at 2.5 to 4 standard deviations above the mean. Now, the features like dangling choroid are subjective findings. They should increase your suspicion, but they're not diagnostic of ventriculomegaly. Hydrocephalus and ventriculomegaly are not synonymous with each other. When you say hydrocephalus, you mean there is a altered CSF dynamics, either due to increased pressure or either due to obstruction or due to increased secretion. But when you say ventriculomegaly, it can be due to that pathology, that is altered CSF dynamics very rarely, but more often it is mild to moderate dilatation of the ventricles due to non-obstructive causes. So these two words are not synonymous with each other. At the same time, there are many other cystic areas in the brain. Dr. Gauri Shankar is going to elaborate this topic. We should not get confused with these cystic spaces versus ventriculomegaly. Ventriculomegaly is not a diagnosis, it is only a symptom like fever. So it should prompt us for further investigation to make a final diagnosis. It is a very heterogeneous entity. There are multiple etiologies and a wide range of neurodevelopmental outcomes. So we should be out to look out for the cause for this ventriculomegaly. And therefore, it requires a very systematic and problem-solving approach. Now, I am going to go through these steps to approach this problem. Always start with the clinical context, pedigree analysis, and then end with counseling on neurodevelopmental outcome only after a reasonable period of follow-up. Now, as with any medical problem, clinical context is most important to start with. Mother's age, consanguinity, any suggestive history in the pedigree, unexplained fever during pregnancy, risk of infectious exposure like for toxo, maternal medical illness, specific risk factor for vascular clastic lesion, maybe coagulation disorder or drug abuse. Looking at the parent's head is also very useful. A dedicated neurosonogram should be performed with the highest possible frequency transducer. Whenever possible, use a TVS. It is very, very useful. Multiplanar acquisition in axial, 4 different coronal, sagittal, and parasagittal views are very helpful. And you must try and acquire and store 3D volumes, and because it will enable you to enhance your images, algorithms, and display multiplanar and render modes. Now, for the further discussion, I'll first take up the mild to moderate ventriculomegaly because their diagnosis and causes are very different from severe ventriculomegaly. Now, it's very common actually, 1 in 100 fetuses may have mild to moderate ventriculomegaly. It is commoner in male fetuses, but the prognosis may not differ, so your approach should be the same. You're set to ultimately get additional CNS and non-CNS ultrasound abnormalities in about 50% of these babies. Therefore, we should be on the lookout for these additional abnormalities. Whenever we get ventriculomegaly, we should always have the habit of examining the near ventricle using an oblique view from the axial view. Try not to measure in this oblique view because you'll always over measure it. Some asymmetry is very common, in fact, in ventriculomegaly. And as long as it is mild to moderate and there are no additional abnormalities, there's no significant difference in the prognostic information between symmetric and asymmetric ventriculomegaly. However, when you find predominantly asymmetrical ventriculomegaly, you should be on the lookout for vascular clastic pattern, which I will elaborate later. You should also be thinking of rare entities, say for example, hemimegalencephaly. Now, whenever you find lateral ventricles are dilated, immediately look at the third and fourth ventricles, because when you follow the CSF pattern, you will identify that there is an obstructive pathology. At the same time, shape, position of these third and ventricles are also important. For example, high riding third ventricle is a clue to ACC, agenesis of corpus callosum. Abnormal shape of fourth ventricle may give you a clue towards very rare syndromes like Joubert syndrome. Always look at the spine. We always talk about rare things, isn't it? But open spina bifida is the most common cause of ventriculomegaly. Don't forget to look at the spine. Look at the midline forks, look at the thalami separation and CSP. Of course, CSP abnormality is a lead sign for many problems of midline of the brain, starting from holoprosencephaly, corpus callosal agenesis, and septal disorders. So look at the presence or absence of CSP, look at the shape of CSP, look at the CSP ratio. Sometimes when there is an intraventricular hemorrhage or a papilloma, choroid plexus may look large. Rarely there may be a tumor inside the choroid plexus, which may be causing overproduction and the reason for hydrocephalus. Very often we find that if a fetus has large CPCs, it may cause transient mild ventriculomegaly, but this is likely to be benign usually. The next, look at the ventricular wall, lumen, periventricular area, and cerebral parenchyma. All these together will give you a pattern because there's a significant overlap in these features. Always go for a pattern recognition rather than looking out at each individual abnormality. For example, there is a vascular insult, gives you a ischemo-hemorrhagic clastic pattern. That means the ventricular walls will be echogenic. There will be subependymal clots like this. There may be synechiae, blood clot within the ventricle, and if the vascular insult is severe, then the adjacent parenchyma may be liquefied, destroyed, leading to porencephaly. So this is a typical vascular clastic pattern. Next is the infectious clastic pattern, mostly due to CMV. Very often you'll find only mild to moderate ventriculomegaly, but there is a typical periventricular echogenic halo that I'm showing you here. There are cystic areas behind the occipital horn of the ventricle, which is very typical of CMV, synechiae inside the ventricles, uh, calcifications in the parenchyma, microcephaly, as well as some sulcation abnormalities. They're all very typical of infectious insult. What about cortical or migrational disorders? Most important clue for this is the appearance of the Sylvian figure. All of us should have this chart in our ultrasound room. We should know how Sylvian figure looks at each gestational age and what is operculization. So if you have the habit of looking at this, you may diagnose migrational disorders and cortical abnormalities as well. At the same time, sometimes if you find the ventricular walls are irregularly indented, you may be encountering a case of nodular heterotopia. If you find very abnormally shaped, square-shaped ventricles like this, it may be, again, it may be a migrational disorder, lissencephaly. So all these things are very, very rare, but you can diagnose the pattern. Always look at corpus callosum in the mid-sagittal view, presence or absence, and how does it look like. Cerebral hemispheres sometimes may be very asymmetric. It may be due to hemimegalencephaly, it may be due to thinning on one side, it may be due to schizencephaly. Very rarely you may find solid or cystic lesions like tumor, bleed, or a cyst in the parenchyma. Looking at the subarachnoid space is very subjective actually, largely overlooked during our scans. And remember, ultrasound can only see the far pericerebral space, unlike MRI, which can look at all, pericerebral space all over. So there are certain patterns here. If you find ventriculomegaly, macrocephaly, big head, with reduced pericerebral space, it is usually due to obstruction. You find ventriculomegaly, big head, but increased space, it's due to benign familial macrocephaly. At the same time, you find ventriculomegaly, microcephaly, and increased space, you should think of CMV. So this is all about the pattern recognition. If you find posterior cranial fossa abnormalities like Dandy Walker or something like that, then the whole diagnostic pathway is different and your counseling and prognosis is going to be very different. Not only looking at the brain, look at all the other things, because you need to diagnose IUGR, you need to diagnose markers of chromosomal genetic abnormalities or infection, and you must do a detailed fetal echocardiography. So what about karyotype and CMA? What is said is about 5% fetuses with apparently isolated mild to moderate ventriculomegaly will have an abnormal karyotype. Most commonly trisomy 21, the risk of which is inversely related to the severity of the ventriculomegaly. If you do CMA, another 10 to 15% will have the abnormality. It is said that if you evaluate isolated ventriculomegaly, up to 9% will yield with the abnormal CMA. So it is said CMA should be offered to fetuses with ventriculomegaly, regardless of the degree or whether combined with other structural abnormalities or not. However, remember, it is not such a straight and simple test. There are many problems with interpretation of CMA and counseling, so comprehensive pre and post test counseling by professional geneticists is a must. Further genetic testing depends on what you're finding in addition to the ventriculomegaly. Typically, single gene disorders may be associated with more severe ventriculomegaly as well as additional abnormalities. Nowadays, a lot of trio-exome sequences is going on. Therefore, we are going to discover more and more novel pathogenic genes. If you see isolated ventriculomegaly, relatively few genetic causes have been identified, and among them, of course, L1CAM mutation is the most frequently detected, accounting for about 30% of suspected X-linked congenital hydrocephalus in male fetuses. Fetal infections are said to be responsible for about 5% of mild to moderate ventriculomegaly. Although you find typical infectious clastic pattern that I described above, infection can also cause isolated mild to moderate ventriculomegaly. You should not forget that. Whenever we send maternal serology, almost all of us get more confused, and it is most of the times inconclusive. So if you want to diagnose for sure, you should go for amniotic fluid PCR. But remember, it is accurate only after 21 weeks and only after 6 weeks of maternal infection. We don't generally do maternal antiplatelet antibody to all because the overall positivity is low and test is not available in many centers. But it is worth testing for this when there is even subtle evidence of intracranial hemorrhage. And to detect that, MRI is very, very useful. However, in some series, 11% screen positive rates have been published. The potential additional role of fetal MRI depends most often on the quality of your detailed neurosonogram, and it is inversely proportional to that. However, when this technology is available, affordable, and this additional information is desired by parents, and most importantly, you have an expert who can interpret the fetal MRI well, then you must go for fetal MRI. There are many specific situations, specific pathologies where fetal MRI is additionally beneficial, and recent series have said the clinically significant additional findings are detected in 1 to 14% of mild to moderate isolated ventriculomegaly. And it is useful only after about 24 to 28 weeks. Definitely helps in counseling couple. It is important to note that the lateral ventricle looks bigger in MRI, but for your counseling and prognostication purposes, you must take the ultrasound measurement and not the MRI measurement. Very essential to follow up these cases after 4 to 6 weeks, because 14 to 16% of them progress, and progression changes the prognosis. And follow-up examination may show additional problems in about 13% of cases, and therefore at least 1/3 trimester follow-up is highly desirable. Coming to severe ventriculomegaly, where the atrium is more than 15 millimeters, it can be obstructive, or it can also be associated with other malformations like malformations of cortical development. Now, obstructive hydrocephalus obstruction can be anywhere, but the commonest site is aqueductal obstruction, and it can be due to a genetically mediated stenosis. Many other developmental problems can cause obstruction like GRE2 or Dandy Walker. Acquired problems like tumor, cyst infection, hemorrhage, anything can cause obstruction. What is important is a normal mid-trimester scan will never rule out an obstruction because it usually manifests later in pregnancy. One of the common clinical entity is aqueductal stenosis. It can be X-linked recessive or it can be multifactorial. And I have already touched upon this. If you find recurring hydrocephalus in male fetuses and the male fetus has adducted thumb, it is likely to be this, and a prenatal invasive testing for this mutation is warranted because the recurrence risk is 50% for all male progeny, whereas the recurrence risk is only 4% when the cause is multifactorial. So there's a typical obstructive pattern in the ultrasound: large head, parenchymal thinning, obliteration of pericerebral space, effaced sulci, compression and destruction of CSP, dangling choroid plexus, dilatation of third ventricular recesses, which is actually a very early sign of obstructive pathology, and an essentially normal posterior cranial fossa. So if you can actually image third ventricle, the cerebral aqueduct, the recesses and everything, but MRI is definitely helpful in identifying the enlarged recesses of third ventricle. So following a systematic checklist mentioned, over the years, you will see less and less isolated ventriculomegaly. And of course, over the years, you'll be more confident in giving good prognosis to the true isolated ventriculomegaly. But it remains a diagnosis of exclusion until the first 2 years of life, because about 7 to 10% of fetuses with apparently isolated mild ventriculomegaly are found to have additional problems after birth. Therefore, if you are what about prognosis, how to counsel? If the atrium is close to 10 mm, it is likely to represent a normal variant. In this slide, I'm only talking about isolated mild ventriculomegaly. When the atrium is between 10 to 12 mm, about 90% of them do very well. It is the same as in general population. And a truly isolated ventriculomegaly up to 15 millimeters, recent meta-analysis have reported that the rate of neurodevelopmental delay is 7.9%, which is again the same as in general population. When it comes to severe ventriculomegaly, it is not a good story. Even if you take apparently prenatally isolated severe ventriculomegaly, 88% survive, but only 40% of them are normal neurodevelopmentally. So, because they're more likely to have underlying genetic syndromes and there's a higher risk of adverse outcome. It is very difficult to predict the need for surgical intervention like shunting, etc. Of course, if you see very big atrium, mostly they need a shunt. Obstetric management should not change. There is no evidence that preterm delivery or a cesarean delivery improves the neurological outcome. But of course, if you find head circumference is more than 40 centimeter, probably it is safer to deliver by cesarean section. If you find a specific cause, recurrence goes by that cause. But if the ventriculomegaly is completely isolated without identified etiology, then the recurrence risk is only about 4% or lesser than that. However, you need to do a detailed neurosonography at the right time in next pregnancy. Thank you very much, and I'm very sorry for the uh, for the glitch in my internet connection. And I'm going to stop sharing now.
Thank you, Dr. Akila. That was a wonderful presentation. And don't worry about the glitches. The very fact that we could start made it uninterrupted any which way. So moving on, we now welcome Dr. Gauri Shankar Paramasivan. He's a well-known figure in the fetal medicine circles. He is by training a radiologist who's graduated from Madurai Medical College, but he spent most of his years in fetal medicine in the UK in the Imperial College, where he was there for 14 years. He's been trained by Kypros Nicolaides, and his present interest is in HIFU, high focus ultrasound in MCDA twins. So he's going to discuss his experience on intracranial cystic lesions. Over to you, Dr. Gauri Shankar.
Thank you for your kind words. It's a great opportunity for me to be part of this bigger Society of Fetal Medicine. I thank Professor Ashok Kurana and Mohit Shah, and I thank Dr. Akila Vasudeva for giving me this opportunity to start. So I'm just going to talk to you through about intracranial cystic lesions, my experience and how we go about this. So basically, when Akila asked me to talk about this, I was quite confused. See, we always have straightforward topics, but then I thought, well, this is also needs some importance because sometimes we see the cystic lesions and we don't know how to counsel these patients. And as my presenter introduced myself, so I started in India, finishing my training in radiology and moved to the UK in 2004 and trained by Professor Nicolaides in fetal medicine and successfully completing my diploma and fellowship. And I moved to Queen Charlotte's, where I had the opportunity to work with Professor Christoph Lees, where I just also improvised my technique on radiofrequency ablation. And before returning back, I just got Professor's blessings to start my center in Chennai. Okay, for the next 20 odd minutes, I'll be talking to you about what is the approach to intracranial cystic lesions, Does role of additional investigations matter? How do we counsel and manage these conditions? And of course, I always show some clinical cases so that it adds value to the theory part of my lecture. So when you look at the classification of intracranial cystic lesions, you primarily divide into three. One is extraaxial. It can be intraaxial or intraparenchymal, or it can be intraventricular. This is a very simplistic way of classifying the cystic lesions. Another way of looking at it is based on the location. It can either be in the midline, or it can be lateral to the brain, or it can be anterior or posterior. So when you look at the common types of intracranial cystic lesions, the most common things which we already know are the choroid plexus cyst, which you will frequently encounter in clinical practice. Then the less common ones are arachnoid cyst, porencephalic cyst, periventricular pseudocyst, cystic PVL, or CVI cyst or cavum velum interposite cyst. Sometimes you get some teratomas and atypical rhabdoid tumors. There are some cyst mimics like the vein of Galen aneurysm, which you should also be aware of. So as I said earlier, you divide based on the location. Extraaxial, it's outside the brain parenchyma. Intraaxial, within the brain parenchyma, or intraparenchymal, or intraventricular. And of course, common things are more common. So I will give one example. So arachnoid is the most common extraaxial one. And we look at the intraaxial or the intraparenchymal, we look at the periventricular pseudocyst or cystic PVL. And of course, the intraventricular one is the choroid plexus cyst. So what matters when we look at these things? The size, the location, and its effects on the adjacent brain tissue. These three components are important when we look at a cyst in the brain, which helps us in the counseling. As I said earlier, the large cysts mainly are arachnoid cysts. Sometimes you get porencephalic cyst. I think Dr. Akila mentioned about the insult to the brain following hemorrhage or following demise of a monoclonic twin, where the other brain gets into severe hypoxemia and develops into white matter injury resulting in a porencephalic cyst. Sometimes there are small cysts, as I said earlier, choroid plexus cysts, cyst of the cavum velum interposterior, or the conatal cysts. These are some of the normal variants which we are seeing in regular practice, and we should be able to identify them accordingly. Right. So when you look at the midline, again, the most common thing which should come into our mind is the interhemispheric arachnoid cyst. The second common thing is the cavum velum interposterior cyst. Again, arachnoid cyst can be usually seen in the lateral aspect as well. It can be the supratentorial, which is also quite common. And when you look at the intraventricular cystic component, it's mainly the choroid plexus cyst, which we look into it. And of course, don't forget the Blake cyst when you look at the infratentorial component. So this picture, most of us would be very familiar. This is a normal 20-week scan when you see this cystic structures in the brain, and we call them as choroid plexus cysts. This is less than 1% is the prevalence, and it's important to know that this is usually observed at anomaly scan, and majority resolve by 28 weeks. The point I like to make here is the size, number, laterality does not influence management. It was previously thought to be a significant risk for trisomy 18. However, it is no longer used for that. However, when you see a choroid plexus cyst, make sure that you look at all the markers from head to foot for a trisomy 18, which you are firmly aware. If you go to the 18 to 23 weeks scan, Professor Nicolay's book will clearly explain to you what to look for the markers for trisomy 18. And if you see and you don't see any of them, and you only see this isolated choroid plexus cyst, you don't even report it because it's no longer considered a soft marker, and it only gives more of trouble and does not warrant further investigation or testing as well. So that's as simple as that for choroid plexus cyst. So again, coming to the next common thing, the extraaxial cyst called the arachnoid cyst. These are the cysts filled with cerebrospinal fluid. They can be either primary or secondary. Secondary is due to hemorrhage, infection, or trauma, whereas primary is idiopathic. The most important thing is it is not connected to the ventricular system, and it is connected to the subarachnoid space. So this is accumulation of cerebrospinal fluid enclosed within the pia arachnoid that does not communicate with the ventricular system. It accounts for around 1% of intracranial masses. The most important thing is this is usually located in a region of major fissures. When you look at the Sylvian fissure, interhemispheric fissure, these are the places where this commonly tends to form. And also it is more common in the supratentorial aspect compared to the rest of the brain hemispheres. Again, when you define in ultrasound, it's very clear. It's an avascular, echolucent cystic structure with smooth walls. Sometimes it can be echogenic if it is associated with infection, when we call it as a secondary arachnoid cyst. The complications mainly result from mass effect to the adjacent ventricular system. And as I said earlier, these are usually diagnosed at the second or the third trimester. Most of them are benign in nature and they usually don't increase in size. But whenever you see an arachnoid cyst, you have to carefully look for if there are any additional abnormalities. For example, you look for an agenesis of corpus callosum, look for other cortical malformations, because arachnoid cysts sometimes can be associated with other abnormalities. And if you find out it is an isolated arachnoid cyst, it has got a very low association with aneuploidy or genetic syndromes and does not warrant any further investigations. I usually perform an MRI at around 28-32 weeks, primarily to check for its effects on the adjacent brain tissue, which aids in the counseling and management. Of course, if it's very big, then I always involve the neurosurgeon to have a little chat about what happens to these babies and how do we manage them, because very rarely it can compress to the cerebrospinal fluid outflow, resulting in hydrocephalus. But vast majority are usually stable and they are best managed postnatally. So this is a clip of an arachnoid cyst. You can see very clearly here. It's an avascular simple cyst with walls. You can see dangling walls. Can you see that? And it's close to the midline. And if you see here carefully, there is a cyst here and the ventricles are seen separate. And as I said earlier, these cysts do not communicate with the ventricular system. Moving on, it's important when you see an arachnoid cyst to look for the possible differential diagnosis. If it is in the infratentorial compartment, you have to make sure that you are not looking at a Dandy Walker malformation or a Blake Park cyst or the megacystina magna. Again, if you look at within the brain, make sure that you're not dealing with a porencephalic cyst or some tumor. So it should be very important to classify and characterize the cyst, as I mentioned before, to make sure that you have these differential diagnoses in your mind before making a diagnosis of a arachnoid cyst. Moving on to the next topic, it's intraaxial or an intraparenchymal cyst. So these again are within the brain, and the most common things which we commonly encounter in clinical practice are the periventricular pseudocyst, which you see here, or it can be a porocephalic cyst, or it can be a cystic periventricular leukomalacia. So the periventricular pseudocyst, you can see this at the level of the lateral frontal horn of the lateral ventricle or its lateral aspect. Sometimes you can see this conatal cysts. These are normal variants, so we should be careful not to interpret them as a periventricular pseudocyst. Again, when we see these structures, largely they are benign but exclude ischemia, infection, and hemorrhage. They are more commonly seen in the chordothalamic groove or the chordate nuclei. It can be unilateral or bilateral. It can be single or multiple. Most of the cases it is due to hemorrhagic event, which subsequently undergoes liquefaction and cystic changes. So I had a case where we did a radiofrequency ablation in a monoclinic twin, and a follow-up MRI showed a small periventricular pseudocyst, and that is because to the acute hemodynamic changes, I suppose, post-procedure, but did not have any further testing, and this settled after some time. So we need to know the etiology. Sometimes it's through infections, and of course, always look for additional abnormalities. Sometimes you get some condition called Zellweger syndrome, where we got cerebrohepatorenal syndrome, where we look at these conditions as well. So always keep your eyes wide and open and look for other clues as well. And if it's isolated, it has got a good prognosis and a normal neurodevelopmental outcome. So these are the pictures you can see on ultrasound and on MRI. These are well-defined cystic structures seen adjacent to the lateral frontal lateral ventricle. Again, MRI T2 weighted images shows clearly these well-defined cystic lesions. Again, they are benign, and as far as the rest of the brain looks absolutely normal, we can be rather reassuring. And as I said earlier, these does not warrant further testing, and postnatally, these babies can be reviewed. Porencephalic cysts, these occur at around 1 in 10,000. And the etiology here is a focal necrosis due to an ischemic event involving a vascular distribution of a major cerebral vessel. So the commonest causes will be a case of intraventricular hemorrhage and its effects, or in a case of a monoclinic twin pregnancy where one baby dies and the next baby exsanguinates, resulting in hypoxic ischemic injury. Sometimes you can also get some infections and some migrational disorders. Porencephalic cyst, again, it's an encephaloclastic type, as Dr. Akila mentioned, and it can communicate with the ventricles to differentiate from arachnoid cyst, which does not communicate with the ventricles. Again, the outcome depends on the site, extent of the lesion, and the insult to the adjacent brain parenchyma. I would strongly recommend fetal MRI in these cases to complement the clinical diagnosis and prognosis in these cases, and which will give us a further good idea of the injury to the brain parenchyma. So this is a ultrasound picture where you can clearly see there is a cystic structure here, and as this is following in hemorrhage, you can see a clot here, and there is ventriculomegaly. So this is a grade 4 IVH with the porencephalic cyst formation. And here is an MRI picture where you can see this cyst has made its way into the ventricle, causing ventricular dilatation. Cystic periventricular leukomalacia is the next common thing which we can see, although this is more seen in preterm fetuses and is a major cause of cerebral injury. However, in term fetuses, we can also see this following hypoxic or ischemic episodes. The characteristic feature is it involves a white matter, resulting in focal necrotic changes and diffuse myelination abnormalities. You can see here, this is where it sits close to the ventricular system here. There is focal necrosis of periventricular white matter, which is a characteristic feature of this cystic PVL. Again, this case will also recommend a fetal MRI to confirm the findings and provide additional information, as I said earlier, to look for the insult to the brain tissue. These are ultrasound pictures which clearly shows characterized by periventricular echo densities. There can be echolucent cysts adjacent to the ventricles, and then also result in ventricular dilatation. So you can see very characteristic location, as I mentioned in the previous slide, of the cystic PVL, and there is ventricular dilatation suggesting possible injury to the ventricular system and extension. Schizencephaly, not a cyst in characteristic, but the way it presents, it usually can be like a cystic structure. It's a rare type of cortical malformation where there is an abnormal cleft lined by dysplastic gray matter that involves the lateral aspect cerebral cortex from the ependyma to the pyometer. It is usually unilateral or bilateral. It can be symmetric or asymmetric. There are two types. There are closed type or an open type. Closed type is usually difficult to diagnose antenatally, while open type is usually easy to diagnose antenatally. Again, the etiology for this is vascular disruption or an abnormal neuronal migration. Of course, when we see schizencephaly, look for septoptic dysplasias where we see the abnormalities of the cavum. Look for gray matter heterotopias and absent CC. So it's important when you see this to exclude porencephalic cyst by looking history of injury, because you know porencephalic cyst is an encephaloclastic event due to injury, which is lined by gliotic white matter, whereas schizencephaly is lined by dysplastic gray matter. And of course, MRI can clarify this when we ask for this specialist investigation. This is a case of open lip schizencephaly where it seems to communicate with the ventricles. And this is a porencephalic cyst where you can see clearly that it's much different to what we see here. So now we have had enough of theory. So let's look at a few clinical cases and see how it can help us in our putting theory into practice. And I always say that proof of the pudding is in the eating. So let's have a little go on some of the clinical cases where we can see. So this is very clear. You see an anechoic, avascular, cystic structure in the midline. And we all know that from the discussion we had, it can be an arachnoid cyst because it is not seen to communicate with the ventricular system. And I also told you that when you look for an arachnoid cyst, you always look at the baby carefully because there can be additional abnormalities as well. So when you look at this baby, there is a diaphragmatic hernia. So these are additional abnormalities which you look into this baby. So this is a case which would warrant further investigation. So this is not an isolated arachnoid, but it's a complex one, and this is particularly a chromosomal or a genetic issue here. So you should be careful to look at the abnormalities when you look for an arachnoid. So moving on to the case 2, I also mentioned to you that arachnoid cysts are usually located interhemispheric or supratentorial. Sometimes infratentorial can also occur. So look at this clip here, and what you see here, there is a cystic structure here in the posterior fossa. So as I said earlier, arachnoid cyst communicates or does not communicate. It does not communicate the ventricular system. But here you can see there is a cystic structure which communicates with the posterior fossa. So it is not an arachnoid cyst, but it is a Blake Path cyst. So it is important to make this characterization, and so which will help us in the clinical diagnosis. Case 3, you see here there is a anechoic cystic structure, and I always make sure that I put color to make sure that we don't have any surprises. And this is one of the surprises. As you all seen, this is a case of a vein of Galen aneurysm. And this usually presents in the second or third trimester with a high output cardiac failure. So I remember when I was in the UK, one of the registrars who was training, he said, I've seen a midline cyst and it's all fine. But then asked him, did he switch on the color? He said, no. And then when I switched the color, it was clearly a case of vein of Galen aneurysm. So it's important, my dear folks, to make sure that we switch on the color to exclude a vascular abnormality. So vein of Galen aneurysm is due to dilated median prosencephalic vein, which drains to the straight sinus. And of course, these are glass body rendering, and which clearly shows you, oops, I moved to the previous one. So anyway, let's move on. Here you see a cystic structure in the midline. And again, as I said earlier, if you remember from a lecture, it could be an arachnoid cyst or a velum interpostae cyst or a dorsal cyst, so on and so forth. So how do we take up from here? There is also ventriculomegaly. So we look at MRI, there is a cystic structure seen below the splenium of the corpus callosum. And this is a very classical location of a cavum veli interpostae cyst. So this is an important thing to remember, that this is sometimes a normal variant and it should not cause concern. The ventriculomegaly is due to an obstruction. This will usually disappear postnatally, and most of the cases does not need further management. So you should be very careful when you see a ventriculomegaly, as the cause for ventriculomegaly is here is just obstruction by this cavum velum interpostae cyst. So this is to conclude, the prognosis depends on the underlying etiology. The clinical outcome depends on the characterization of the cyst, location, and its effects of compression to the adjacent brain and ventricular system. As I said earlier, vast majority are benign in nature and can be managed perfectly well, and they can be managed postnatally. It's important to have fetal MRI since it provides valuable clues and additional information in the management of these conditions. And it's also important for us to arrange appropriate prenatal counseling, and follow-up camps are crucial to the antenatal management. And I thank you all for your kind attention. Thank you.
Thank you, Dr. Shankar. There was indeed a comprehensive coverage of all the intracranial cystic lesions. In fact, both the lectures have been extremely good and precise and quite understandable, because we don't seem to have even a single question in the chat box. So that speaks volumes about your, communication with the audience. So moving on, we would like to now start with the case-based presentations. where this session is going to be moderated by Dr. Akila, and it's going to be a case-based discussion on ultrasound, genetics, and neuropathology. So over to you, Dr. Akila. Please introduce your speakers and get the session going.
Yes. Unfortunately, we could not have Dr. Anita on board for this because I wanted this mainly a sonopatho genetics case series. But of course, I think we'll definitely learn from cases by comparing ultrasound to pathology. That is the basic idea of this particular session. This session is going to be mainly presented by Dr. Shalini. Mr. Vishal, I am going to share my screen. Is that okay?
Yes, ma'am. No problem.
Just give me a moment. For us in KMC Manipal, Dr. Shalini teaches us anatomy and pathology, and because of the perinatal autopsies, the huge number of perinatal autopsies which are done by Dr. Shalini, every time we do an ultrasound and then we correlate with the autopsy specimens, we are getting better and better. So Dr. Shalini Nayak has pursued her PhD in medical genetics in 2017 from Manipal University, which is Mahe now. And currently she's working as assistant professor at KMC Manipal since February 2018. So she's got a lot of research interests, and mainly it is on perinatal pathology, genomics of fetal malformations, and fetal radiology. She's also an expert in interpreting fetal, MRIs. She's got more than 25 publications in high impact journals. She's got extramural project already sanctioned by DBT on congenital heart defects, and she's got several awards and honors as well. So over to you, Dr. Shalini. And I will be moderating the session in the absence of Dr. Anita and Dr. Rupa and Dr. Nivedita, who are actually currently fellows in the Division of Fetal Medicine in KMC Manipal. They will be correlating the ultrasound and the pathological specimens. Over to you, Dr. Shalini.
Hello. Good evening, all. I guess my screen is visible.
Yes, Shalini.
Click on full screen.
Yeah. I would like to thank Dr. Akila for the nice introduction, and the organizers for giving me an opportunity to share these cases. To begin with, we ascertained a consanguineous family with 3 fetal losses, and the ultrasonography in first and third pregnancy, that is at 21 and 17 weeks of gestation, revealed cerebral ventriculomegaly. Then there were kyphoscoliosis, bilateral clubfoot, and Dandy-Walker malformation. Whereas in the fourth pregnancy, the fetus had severe ventriculomegaly, flexion deformities, and club feet, that is at 17 weeks of gestation. And we received this fetus for postmortem examination. So here are the photos of that fetus, and the fetus had contractures across all the major and minor joints of upper and lower limbs. So we can appreciate that in these 2 images. And the fetus also had kyphoscoliosis, and there were facial dysmorphism. On examination of the brain, it was collapsed due to severe ventriculomegaly and very thin brain parenchyma. So the first image here, it is depicting collapsed brain in the cranium, and the second brain, here we are viewing this from the inferior view, and we can see here the brain parenchyma is very thin and ventricles are large. The third image is also depicting These are the ventricles. They are very large, and the brain parenchyma is very thin and it looks transparent. In the fourth image, we are able to see the hypoplasia of the cerebellum, and this is the dilated fourth ventricle. So this is an Dandy-Walker malformation. And the histopathological examination of this brain revealed there was calcification of cerebral and cerebellar parenchyma. Now I request Dr. Rupert to talk on these slides.
Yes, thank you, Dr. Shalini. So, good evening, everyone. So, this slide basically tells about the correlation of the ultrasound findings with the autopsy images. So, in the first image, you can see an actual section of the head with severe ventriculomegaly and thinning of the brain parenchyma, which is as seen in the autopsy. And in the last image of the ultrasound, we can see that there is it is this one transcerebellar coronal view, which shows a small cerebellum with a dilated ventricle. Over to you, Dr. Shalini.
Yeah, thank you, Rupa. We performed exome sequencing in this family to identify the genetic etiology, and we identified here a deletion that is in the gene FLVCR2, so which is known to cause this syndrome, that is nothing but proliferative vasculopathy and hydrocephaly syndrome. So this is also called as Fowler syndrome. So here, this syndrome is an autosomal. This has inheritance of autosomal recessive pattern, and here the risk of recurrence in subsequent pregnancies, that is around 25%. And here we can see the CNS malformations. They are associated with Fowler syndrome. So our fetus had almost this ventriculomegaly, cortical thinning. Then we can see Dandy-Walker malformation, calcification as well. Now I request one minute.
Yes.
1 minute, ma'am. So this is the here is the table which is summarizing the clinical findings in 7 fetuses with Fowler syndrome. So here we can see the gestational age at the time of diagnosis and ultrasound and pathological findings. And here also we can see almost all of them had ventriculomegaly and joint contractures on antenatal examination. Yeah, now I request Dr. Akila Vasudev to give her inputs.
One thing that we learn from this case is that as a teacher in trying to teach fellows in fetal medicine, I always found it very helpful to correlate the autopsy images to the ultrasound images. So Shalini, if you go back to that slide where you show the very thin parenchyma and the coronal image. So the moment you show your fellows or the students, this is how the actual specimen looks like. And these are the actual anatomical structures which you are imaging in the ultrasound. I found this is one of the best method to learn neuroanatomy, which is always a very difficult ultrasound to learn. Among all the ultrasounds, I think fetal medicine fellows, whoever is trying to learn fetal medicine will find learning brain is very, very difficult. But learning brain with Shalini specimens is really, really easy, because that is how the students understand what is the section that I should go through and how actually a thin parenchyma looks like and how fourth ventricle looks like in Dandy-Walker. So that is the first point. And the second point is that the more morphological information you give from the autopsy, I think the genetic testing is very nicely directed. So that is the best way of making a genetic diagnosis with the maximum morphological information. These are the two messages I would like to give to all the fetal medicine specialists out of this particular case. So over to you, Shalini.
Yeah, thank you, ma'am. Here is the second family with the fetus that had Dandy-Walker malformation and complex congenital heart disease on prenatal diagnosis at around 21 weeks of gestation. So when we received this fetus for examination, the fetus had facial dysmorphism, and here we can see this is the image of pulmonary artery, and here are the pulmonary walls. So here they are thickened. Okay, we can see thickened pulmonary walls and dilated pulmonary artery, as well as this fetus had bifid uvula. Here we can see this is the mid-sagittal section of the brain, which is showing agenesis of corpus callosum with the probst bundle at that region. And here this is the section of the brain stem, and we could see this is the here is the hypoplastic vermis and dilated fourth ventricle. In this picture, we are viewing from the posterior aspect, and here we can see arrows that are showing the hypoplastic cerebellum, and this asterisk, it is showing the dilated fourth ventricle. Now I request Dr. Rupa to take over.
So once again, here there is a correlation of the pathology specimen with the ultrasound images. You can see the first image as a mid-sagittal section, and you can see that there is a small vermis which is elevated and like hypoplastic, and you can see that there is absence of the corpus callosum. So along with that, if we add on the power Doppler to this, you can see that the course of the pericallosal artery is very abnormal as compared to normally where it curves through the corpus callosum due to the absence of the corpus callosum. Next slide, Dr. Shalini. So it is not only important in the mid-sagittal section that you see for the absence. If it is absent, you can see it quite clearly. And one more thing is you have to also observe the size, shape, and morphology of the corpus callosum, which can be abnormal, and that also is a significant finding which has to be observed. Thank you, Shanli. You can take over.
Thank you, Rupa. In this fetus, we also could perform postmortem MRI of fetal brain. Here we could confirm the findings like agenesis of corpus callosum and cerebellar hyperplasia with dilated posterior fossa. In view of multiple congenital anomalies in the fetus, that is agenesis of corpus callosum, Dandy-Walker malformation, then complex congenital heart disease, facial dysmorphism, and bifid uvula. So we performed chromosomal microarray from the fetal DNA, and we found a large duplication that is in the first image. So here there is large duplication that is on chromosome 2nd, and a large deletion that is on chromosome 6. So thus explaining the phenotype in the fetus. So now I request Dr. Akila to put in her thoughts.
So again here we have become wiser and wiser in diagnosing corpus callosal abnormalities because of the correlation to autopsy images. That is one thing. The second thing is that all of us have had these overlapping type of pictures when it comes to posterior cranial fossa abnormalities. I think as practicing fetal medicine specialists, we agree that there is a very thin line sometimes between inferior Vermian, hypoplasia and Dandy-Walker malformation. Sometimes we may overdiagnose Dandy-Walker, or we may not diagnose Vermian, hypoplasia, etc. Again, when we start correlating our ultrasound images to that of the autopsy specimen, slowly over a period of time, we start getting wiser and wiser to classify the posterior cranial fossa abnormalities correctly into one of those four categories that we all should be categorizing them into. So again, correlating our ultrasound images to autopsy specimen is very, very important here. And the second important learning lesson from this case is the usefulness of chromosomal microarray. I've already touched this aspect in my lecture on ventriculomegaly. Definitely when there is a morphological abnormality in the fetal brain, it is, I think, much, much better to go for chromosomal microarray rather than karyotype. The more we do, the more we realize nowadays that we get better yield out of chromosomal microarray. I hope Shalini agrees with this, and what is your experience, Shalini? You must be finding a much better yield with the chromosomal microarray.
Yes, ma'am. Usually, whenever we see congenital anomalies in fetus, the first tier of testing we do is chromosomal microarray. So then, if we get any diagnosis, then it is done. Otherwise, means if it is normal, then we will go ahead with further testing. So that may be exome sequencing and genome sequencing.
So, okay, so you can take over, Shalini, to the next case.
Yeah, here I would like to add one point. So whenever we are suspecting deletion and duplication in the same fetus, so that indicates mother or means couple may have, they may be carriers of a balanced translocation. So to rule out this, we need to do their karyotype and we need to find out whether they are really having balanced translocation or not. But unfortunately, in this family, we could not do that. Yeah, thank you, ma'am. So we will move on to third case. So the family 3 was referred in view of stillbirth, that is at 28 weeks of gestation, and the ultrasonography showed oligohydramnios, asymmetrical hydrocephalus, and they suspected there may be left schizencephaly. So when we examined the fetus, we saw there was no dysmorphism in the fetus. And however, this is here we can see this is the cranium that is from the posterior aspect. So when we saw that this is the occipital bone, and there was defect in the occipital bone, which was very small. And the examination of the brain showed that part of the frontal and parietal lobes of left cerebral hemisphere were missing. So we can appreciate here, this we are viewing from left lateral side, and part of the cerebral hemisphere is missing here. And in this picture, this is we are viewing posterior fossa from the back side, and we could see it was filled with lots of old blood clot. Here in the first image, we can appreciate the porencephaly, and you can see this is the frontal lobe, parietal, occipital, and temporal lobe. And you can see here this part of the left cerebral hemisphere, which is mostly supplied by left middle cerebral artery, that is absent. And whatever the cavity you are able to see, this is the ventricle. And in the second image, here you are viewing the brain stem from posterior aspect, and these arrows they are showing disruption of the cerebral hemisphere, and this asterisks indicate this is the fourth ventricle. So here there was total disruption of the cerebellum. And this is the image of brain stem. We are viewing from the lateral aspect, and this arrow is showing. So here we can see part of the cerebellum is there, but majority of that is disrupted. Now I request Dr. Nivedita to talk on these slides.
Thank you, Dr. Shalini. Here you can see that the whole parietal lobe is missing. This is a MRI image from the literature of the different fetus, where you can see both parietal and occipital lobe is missing. So this is mainly porencephalic cyst, which is due to clastic or disruptive pathology. Next slide. So here you can, in the ultrasound images, in A and B image, you can see both parietal lobes are involved. So in the ultrasound image C and D, you can see there is involvement of the cerebellum also. D is the MRI image of the same fetus of which is shown in image C. So this is a typical disruptive clastic pathology of vascular origin, showing a huge parieto-temporal porencephaly with residual intraventricular hemorrhage, complete non-visualization of cerebellum, mostly due to ischemo-hemorrhagic insult in certain vascular territories. For example, PCA and MCA territory in these images. Over to you, Shalini.
Thank you, Dr. Nivedita. Yeah. So this schizencephaly, as Akila ma'am explained, is thought to represent a true malformation with clefts which are lined by gray matter, whereas porencephaly implies to an encephaloclastic events, mainly ischemia. So here we can see the variants in few genes. They are known to be associated with schizencephaly, whereas this isolated porencephaly is mostly a vascular origin. And here whatever you are able to see, this is an syndromic form of porencephaly where there are ocular anomalies as well. Now I request Dr. Akila to share her experience regarding this case.
Basically, in any of these cases, as fetal medicine specialists, when we scan, we should try at least to classify them as whether it is a developmental anomaly or it is a disruptive anomaly, because the etiology of a developmental anomaly is very different. It is very often genetic, and therefore the prognostication, the implication, the outcome is very, very different, and the recurrence risk is also very, very different. Whereas when you are dealing with the disruptive or a clastic vascular pathology, it usually affects that pregnancy, that particular vascular territory. Of course, that pregnancy has a poor outcome, but it has no etiological implications usually to the next pregnancy. So as a fetal medicine specialist, I think whenever you image brain, you should try to fit that into either a developmental anomaly or a disruptive anomaly. So that is one message that we would like to give out of this particular case. Over to you, Shalini.
Thank you, ma'am. So now we will move on to fourth family. So this family presented with severe ventriculomegaly, a dilated third ventricle, and a normal posterior fossa in a fetus at 21 weeks of gestation. So when we examined the fetus, we saw there was no dysmorphism. And in this fetus, we could perform postmortem MRI of fetal brain. And in this image, we can see these arrows, they are showing dilated lateral ventricles. And here circle, in between here, we can see this is the dilated third ventricle that is on fetal MRI. So on examination of the brain, we could see severe dilatation of lateral ventricle. So here we can see this is one cerebral hemisphere. This is another cerebral hemisphere. And here the lateral ventricles, they are really enlarged. And here this is the part of the brain stem. And here is the thalami. And in between the thalami, you can see here, this is the dilated third ventricle. Yeah. So here we can see this is again same image enlarged. So here we are viewing the brain stem that is from posterior aspect, and these are the thalami, and in between that you can see this is the dilated third ventricle, and here is the midbrain, And here we can appreciate this is the normal cerebellum. And when we took the mid-sagittal section of this brain stem, we could see here thalami, and this is the midbrain. We can appreciate tectum and tegmentum here. And usually the aqueduct, the position of the aqueduct will be here, but we can see there is stenosis of the aqueduct, or there is obstruction. And if you see the fourth ventricle, that is normal, and even the cerebellar vermis is also normal, and pons and medulla, that was also normal. Now I request Dr. Nivedita to take over.
Thank you, Shalini. Following the CSF pathway is possible using neurosonogram, though MRI is more useful. But in order to detect the obstructive pattern, we have to see the CSF pathway as well. So in the image, you can see it is a mid-sagittal image of actually it's arachnoid cyst, but this image we have put up here to show the aqueduct. Can you play the video?
Yeah.
In the video, actually, you can see the midbrain and the aqueduct and the vermis, pons, and the medulla. Actually, if you scan carefully, you can see the aqueduct. So axial and mid sagittal section both are useful. The first image is axial image, which is showing the aqueduct. Next image, please. So this is MRI. MRI image is more useful compared to the neurosonogram. So first image is a normal MRI image. So in the mid-sagittal section, we can see the normal corpus callosum. Though we cannot identify the third ventricle, but we can make out the recesses. The black arrowhead show the recesses of the third ventricle. The first one is supraoptic recess and the down one is infundibular recess. The white arrowhead shows the aqueduct of Sylvius and the asterisk shows the fourth ventricle. The black arrow shows the tectum. So coming to the second image, which is showing the abnormal image with a dilated third ventricle and aqueductal stenosis. The tectum is very prominent. The white arrow shows that the recesses are dilated, and the corpus callosum, which is shown by the black arrowhead, is very thin and it is pushed upwards. This third image is of the same, this is a postnatal image of the same fetus. Over to you, Shalini.
Thank you, Nivedita. So based on our autopsy findings, it was suggestive of X-linked hydrocephalus in the fetus. So it is most commonly caused by mutation in L1 gene. But however, we could not perform any genetic testing in this family. So with this, I request Dr. Akila to comment on this.
Commenting on this last patient, Shalini. So it's unfortunate that we could not make a genetic diagnosis in this patient because many a times the aqueductal stenosis will come into picture in the ultrasound only later on in pregnancy, isn't it? Yeah. Making an early diagnosis or in Indian context, making a timely diagnosis is very difficult for some of these obstructive problems of CSF. So whereas if you can make a genetic diagnosis, you can make such a diagnosis much before the true picture comes in the ultrasound. So that is the usual scenario in our setup. Many families, even after extensive counseling, they do not realize the need of a genetic testing until unless repeated pregnancy losses occur, and then finally they'll be convinced to go ahead with the genetic testing. I'm sure your experience says the same. I think this is the last case in this series. Shalini, if you want
yes,
so if you want to give a message to the fetal medicine specialists who have joined this webinar from your side, you can actually give some important teaching messages from your side, and that will conclude this session, Shalini.
Thank you, ma'am. Actually, I would like to give awareness that suppose if there are anomalies, they are diagnosed on antenatal ultrasound, and then if the family is going for termination or there is stillbirth, so please refer them to the genetics clinics or perinatal pathologists who are doing the fetal autopsy. So it will be good for them. That sometimes what happens is some minor things, for example bifidula or some minor things, they may give clue for some diagnosis, so that we will find in autopsy, and we will confirm those anomalies also. Sometimes it will add, and it may change the diagnosis as well, and we can keep tissues. So if you are sending the fetuses in cell line, so we can take tissues from the fetuses, and we can extract DNA from them. So if they are willing to do any further genetic testing, so they can have backup with them, and they can offer those testing, so that it will be helpful for the family for future counseling. And based on the diagnosis, suppose if we have a diagnosis in our hand at 12 to 13 weeks of gestation, we can do CBS and targeted testing for that whatever mutation we got, and we can give them the diagnosis. So this is from my side.
Thank you, hope everybody has enjoyed these clinical correlation sessions. Dr. Khurana, this was a small attempt from our side to tell you all how we learn from each other. Thank you. Over to you, Dr. Khurana.
This was absolutely marvelous. I didn't realize that this evening would have such delicious content. And it's truly a fabulous learning experience. And believe me, it's way ahead of even world class. Congratulations to the whole team. We have a few minutes before we move on to the next lot. And I want to take this chance to ask some of the questions that were there, which came in later. And the first question is from Dr. Manohar, and this is for Dr. Akhila, the importance of distended suprapineal recess in obstructive hydrocephalus.
So all this actually, please believe me, I did not know much about all this before giving this lecture. I realized there are certain things that you can see much before the obstructive pattern. So when you say it is an obstructive pattern, you already see macrocephaly, ventriculomegaly, etc. But that's usually coming up later in second trimester or third trimester. So people have actually diagnosed very early patterns in obstructive ventriculomegaly because these recesses of third ventricle, which are suprapineal, the supraoptic, the infundibular recesses, they actually enlarge in as an early sign of aqueductal obstruction. So if you want to stretch your limits and diagnose more and more, then you can start looking at all these recesses and try and make an early diagnosis. That will help the couple, because it is maybe you're only encountering a mild ventriculomegaly in early pregnancy. Your counseling is going to be very favorable, isn't it? But whereas if you see these early signs of obstruction, the diagnosis itself is different there, and the counseling is different, and the prognosis is different. So it's only stretching the limits, that's all. I'm really not telling you that you have to make all these diagnoses in all patients.
Yes, but when we start looking, we're going to find these. And yes. I used to not even believe that you could see these recesses. And then I realized that they're beautiful wedge-shaped recesses in the normal situation. And the moment you find a finger-type recess, then automatically you start saying, I must follow this up more carefully. I must prognosticate more carefully, and therefore counsel quite differently.
Yes.
Thank you very much for that question and for that lovely answer. There are two questions for Dr. Gauri Shankar. And the first one is from Dr. Anupam Bhala, and the need to differentiate. How do we differentiate a conatal cyst from a cyst from periventricular leukomalacia?
That's a fantastic question. Thanks for asking that, because one is a normal variant while other is an abnormality. So conatal cysts are usually seen at the superlateral aspect of the frontal horn of the lateral ventricle. Whereas if you look at my previous slide, I showed the periventricular involves the white matter just more anterior. And of course, there will be some signs of necrosis and infection and things like that. Whereas in a conatal cyst, we can see the cyst margins very clearly. Whereas a PVL will always show signs of periventricular densities. It can just lead to ventricular dilatation and so on and so forth. Having said that, you have to just be very careful, and always, that's why the reason to have this follow-up scans. Conatal cysts usually don't enlarge in size. They are very tiny and they persist, whereas PVL usually can change its position and its characteristics over the course of the gestation.
Yeah. And the second question for you, cyst of quadrigeminal cistern versus the cavum velum interpository cyst.
Yeah. That's an excellent question. Again, these are the ones when we look at the midline cysts and we have to identify them based on the location. And that really triggers more to learn about the neuroanatomy and the development anatomy, I would say. If you look at the cavum velum interpository cyst, which I showed my MRI picture clearly, it is located below the splenium of the corpus callosum and it's above the cerebral veins. Whereas a quadrigeminal cistern is more lateral and it's below cerebral veins. And also, when you look at an axial section on a ultrasound, it gives a triangular configuration of a CVI, which is more central, whereas in a quadrigeminal cistern, it's slightly eccentric. And I think that will help us. And of course, if we have any problems with this, we can always get the help of our radiologist who are experts in fetal MRI, who can just help us clarify these findings. But the final... Yes.
Quite rare to find, if you ask me. Thank you so much for those questions. We will now take our so-called commercial break. We have some...
Back. Yeah.
Thank you. We get back to the next session. And before we take over, we have time for an audience interaction. And we have such tremendous congratulatory messages for the mid-session as well. And people have greatly appreciated the fact that these were excellent autopsy specimens, that there was fantastic case workups, and congratulations to the entire team and what has been suddenly named as the Manipal gang. I love that word. Well, thank you for ganging up to teach us so much this evening. Before we move on to the next thing, there are 3 questions for the neurosono case pathologies. And I think Dr. Shalini or anybody on the team can take these over. And the first of these is brain preservation for autopsy, general guidelines for obstetricians or for the pregnancy termination room. Any special efforts to be made for this?
No, I would suggest once it is expelled, they need to preserve in a saline if they are sending fresh fetuses. That is within 12 hours, if they are sending it for a perinatal pathologist, so then they can store in normal saline. And suppose if they are sending after 12 hours, then we prefer that they need to collect some tissue. So it can be umbilical cord or some skin tissue in saline, and fetus they can store in 10% formalin so that there won't be any autolysis. And these tissues, whatever they're preserved in saline, they can be used for extraction of DNA.
Excellent. But in terms of preserving the brain so that it doesn't get autolyzed in transport?
Yes, sir. That is what I meant to say. So if it is within 12 hours, we can manage. If they are sending the fresh fetuses and it will reach the pathologist within 12 hours, then it is fine. Otherwise, they need to put it in formalin. So once we receive the fetus, we also inject the formalin into the brain and we will fix it for 3 to 4 weeks from our side.
And you don't think we need to inject formalin into the fetal brain like we used to in the good old days through the fontanelle and just leave it there?
No, sir. No, sir. Usually, sometimes what happens is we might not be able to get DNA or something. So that's why we prefer, pathologists to do that.
Wonderful. Thank you so much. Because I think you're going to receive specimens more than 12 hours. They're going to be deposited. They're going to be dispatched to you from all parts of the country. Because, we don't have too many perinatal pathologists. So you're going to have to give us your courier address and, perhaps we can make an announcement for this, because we often have long waiting lists for perinatal pathology, many months, and
Okay,
that's a
okay,
complete
okay.
disaster. There's another very interesting question, and this is on the matter of an MR necropsy. You did refer to it in one of the cases, and would that be the procedure of choice? How should we handle this versus a true perinatal pathology?
You mean to say MRI? MRI of fetal?
MR
Yeah. So MRI, it depends. Usually MRI, if we are doing, we need to do in fresh fetuses.
Mhm.
And so if we inject the formalin and if we are doing MRI, so that may give, means it may lead to some artifact and also we may create some spaces, cyst, those things may come up, and there may be autolysis also. So it is better if we are doing MRI, we have to do within 12 hours.
Okay.
In fresh fetuses, yes.
And another question on the type of microarray to be done on the amniotic fluid or CVS in these situations. Do we do the low end, the medium end, or the high end microarray to look for microduplications and microdeletions? The 750K or the lower end?
We can do anything. It is just means resolution will be different, but
Yeah.
all the microarray, whatever they are available, customized microarray, they will pick up known microdeletion and duplication syndromes. So majority of them will pick up. So whatever is available and whatever is suitable, so they can do those type of microarrays. Here usually initially we were doing 650K array, but now we started 750K microarray.
Wonderful. So, because the patient then expects an answer that, oh, you made so much of an effort, and will everything be fine in my next pregnancy? So I think it's really marvelous that we are managing to give so many answers to so many patients. I know it takes a lot of hard work, and we struggle in the field of genetics because we don't understand it ourselves. So it's nice to have support like this. Your opinion, Dr. Akhila, on what a marvelous method of actually going through these cases and explaining to each one of us how to understand these and how to apply ourselves.
Yes, actually at Manipal, I should say, Dr. Khurana, that we are spoiled. We are quite spoiled by an excellent genetics team behind us. So we don't literally have to break our head on genetics. We have all answers to genetics related problems. But I'm sure that's not the case with everyone. That's not the case with everyone. So what I would say is, before sending the any tissue for even amniotic fluid for chromosomal microarray, it should not be sent like how we send karyotype, because we should be able to deal with the results, isn't it? And many a times you get VUS, you get some regions of homozygosity in consanguineous couple, you find something which is unusual, which you cannot fit into your phenotype, you get into deep trouble. Then you don't know how to counsel the patients. So I think more than doing an amniocentesis and sending for CMA, it is a very good pre-test counseling backup that you should have. So find somebody who is very good in pre-test genetic counseling, then you can do amnio and send for CMA or karyotype or whatever you want to do.
Wonderful. Also, we've learned so much on which test to do. I'm completely overwhelmed by the degree of wisdom we're getting in this program. Thank you so much for this part of the program and the first part too. And time to move on to the last part of the program tonight. This is your panel discussion, yes, on learning from case-based fetal CNS abnormalities. So over to the moderator, Dr. Gauri Shankar Parasamam.
A very good evening, and it's very nice to see still over 250 people are still tuned into this program, which is a huge success. And thank you, Professor Khurana and Dr. Akhila Vasudeva, for organizing this wonderful event. It's very nice. And now food for thought. And then we know that CNS abnormalities are the most diverse and most complex ones. And they are the most scary ones as well, because they are not the black and white ones. They are always the gray ones sometimes, which needs a lot of input in terms of counseling, management, etc. So now what we are going to do this evening. We have got a wonderful team of an excellent panelists who are masters in their own field of specialty. And I'm going to introduce them to you, and then we will start discussing these cases. So I'm just going to share the list of the panelists who are going to be with me this evening. Yeah. So we got Dr. Rupa and Dr. Nivedita, who are fellows in the fetal medicine, working with Dr. Akila Vasudeva, who will be showing us the cases. And Dr. Akila Vasudeva, who has been here, and then she'll be giving her input in terms of obstetric management of these cases. Dr. Rajagopal, who doesn't need any further introduction, he's a great person who is a professor of radiodiagnosis in KMC Manipal. He has done his fellowship from the Royal College UK, and also has done an abdominal imaging fellowship as well. He has got more than 100 journal publications, and he has co-authored many papers, and he has got several research projects. It's said that Dr. Anita Mahadevan will be joining us this evening, and we wish all the best for her. And then Dr. Leslie Lewis, who's an neonatal consultant at KMC Manipal, will be sharing his experience and expertise in managing these babies with abnormalities. Shalini Naik, who has given a lot of input into this lecture, and then she'll be sharing her input in terms of genetic counseling and management in these cases we're going to discuss this evening. And to mention Girish Menon, who is a professor of neurosurgery, because we all, when we diagnose these cases of abnormalities, we don't know what happens after the baby is born. And then we need to know from this person what exactly happens, so that will help us in the counting. So we've got the stalwarts today, and I'm going to show the cases for this evening. 1 second. Okay. Right. Okay. 1 second. I'm just still. Yeah. Okay. Now this is. Okay. Yeah. Okay, right. Are you able to see my slides now? No.
Not yet, sir.
Okay. Right. Okay. Share screen, and now it should come. Right. Now it's fine. Okay.
Perfect.
So, right. Good. So fetal CNS abnormalities, straight from the horse's mouth. That's what you're going to listen and hear from now, from the experts. How do you manage these cases? Okay. So case one, and I would like to ask one of the doctors to start, Dr. Shani Nivedita.
I'll be presenting the first case. Actually, she was a 39-year-old multigravida who presented to us at 31 weeks with an ultrasound report, which was suspicious of a neural tube defect. Her antenatal care was abroad, and due to the lockdown, she could not come earlier. And scans there showed that the 19, 23, and 26 week scans showed that there was bilateral prominent occipital horns with mild loss of normal expected curvature of the lower dorsolumbar area of the fetal spine. And successively, the scan showed that the BPD was less than the third centile, and there was dilated supratentorial ventricular system with a small cerebellum and deformed lower spine.
Okay.
She came to us at 31 weeks over here, and we found a large lumbosacral defect with a gross ventriculomegaly with Arnold Chiari malformation found.
Okay. Yeah. I need to stop you here, Rupa, and I'm just going to ask Dr. Akila. Akila, are you around?
Yes, Gauri.
Yeah.
Yes.
So I need to ask you, but she had some previous scans in Dubai, and that is not diagnosed here. So can you just tell us how early can we diagnose neurotube defects, and are there any close in 11 to 14 week scan?
Of course, we all now know that we can get enough clues in the 11 to 14 week scan, starting from the simplest thing, that is a small BPD, which can pick up almost half of the open neural tube defects, the crash sign, where the aqueduct and the cerebral peduncles go back and crash against the cranium posteriorly, dry brain sign, the reduced or absent intracranial translucency. And many times with the high frequency TVS probe, you can actually see the neural tube defect rather than going through these indirect signs. I think we should be able to do a good NT scan and diagnose many NTDs in the first trimester, Gauri.
Thank you. And then not to forget the intracranial translucency as part of the
Translucency,
routine.
yes, I said that, yeah. Yes.
Okay, good. Excellent. So, Rupa, can you just tell us about what happened to the delivery and neonatal details?
Yes. Further, she continued her ANCs with us, and she was a case of previous 2 cesarean. So she underwent an elective cesarean with sterilization in this pregnancy. And what we found was in the spine, there was a transparent membrane covering the notochord and mainly in the lumbosacral area. The defect was around 5 to 4 centimeters, or else there was no evidence of any CTV and no other abnormalities seen. When examined, there was some amount of hypotonia and decreased reflexes in the lower limb, but the anal wink was there and the anal sphincter was non-patulous.
I need to ask Dr. Akila here, do you normally deliver these babies by section, or can you deliver them vaginally? You're muted.
I'm sorry.
Yeah.
As far as the literature goes, I think you're not really going to do much improvement in neurodevelopmental long-term outcome by doing cesarean for all these babies. That's not really meant to be done. But when there is a large meningomyelocele, in practice, many times we go for cesarean section and try to deliver with minimum trauma to the open neural tube defect.
Okay.
I hope most of you agree with me.
Okay. Right. There are some neonatal MRI pictures here, and I would like to involve our radiologist, Dr. Rajgopal, to throw some evidence or his findings on these cases. Dr. Rajgopal?
Yeah, can I share my slides?
Yeah, of course.
Yeah.
I'm going to stop sharing now.
Okay.
Yeah. I've stopped sharing now. You can share now your slides, please.
Okay. Yeah, I totally agree that the ultrasound is a fantastic tool to image neonates as well as the fetuses. But however, the MR sometimes it gives a problem-solving tool, especially because it has a wonderful soft tissue resolution among the soft tissues. And in addition to confirming the diagnosis, it also gives some additional clues to the diagnosis as well. So in this case, what we're seeing is a mid-sagittal plane, and normal anatomy has already been discussed earlier by previous speakers. And here I'll show you some of the findings in this particular case. So here in the mid-sagittal plane, what you're seeing is a very small posterior fossa and small cerebellum there. And you can see the herniation of the cerebellar tonsil, like a pointed herniation of the cerebellar tonsils below the level of foramen magnum. Okay, and even if you see the fourth ventricle, it's elongated, right? And even in the region, there is a tectal beaking also in the region of the midbrain. And in the massa intermedia also, it's very, very prominent in this case. Okay, and even torcular hierophili, where it's a where the superior sagittal sinus combines, where it touches the transverse sinuses, the torcular hierophili, it's actually totally displaced downwards. And you can see the posterior fossa, which is so small, right? And in the axial image, you can see The posterior fossa, again, it's very, very small. And the fourth ventricle is almost elongated and partially effaced. And the third ventricle is significantly enlarged. And the lateral ventricles, when you see here, you can see the colpocephaly, the dilatation of the occipital horns of the lateral ventricles, and the both lateral ventricles are significantly enlarged, and the third ventricle is also enlarged. I mean, giving the information that possibly you may be dealing with obstruction at the aqueduct of Sylvius. So there is a stenosis at the aqueduct of Sylvius in this case. Moving on to the further imaging, like these are some of the T2 weighted scan and there is a T1 weighted scan. Essentially, we take different sequences to look for the soft tissue resolution between these structures very well. Okay, so the different sequences will give more information. Like in this T2 weighted scan, what you're seeing is again you see the herniation of the cerebellar tonsils below the level of the foramen of magnum, and here beautifully you can see the spinal cord here. Here, lower dorsal region, you can see the spinal cord going into the region of the myelomeningocele here. Lower dorsal as well as the upper lumbar region. You can see the spinal cord going there and it's got tethered there as well. And it's lined by the membrane outside. It's the posterior elements are totally not formed at all, at this level, suggesting that there is a myelomeningocele. This component of meninges, CSF, as well as the spinal cord going there. And even you can see the spinal cord going downwards as well, and there's a tethering of the spinal cord lower down as well. Okay, so it showed almost a similar information what you saw in the ultrasound, but with a better resolution, and it's totally not operator dependent. When you see the axial images, just above the level of the myelomeningocele, you can see the prominent central canal here. This is spinal cord, and this is his prominent central canal, so suggesting that there is a syringomyelia just above the level of the myelomeningocele. And at the level of the myelomeningocele, you can see the posterior elements are not formed at all. And you can see the spinal cord going down, going into the region of the myelomeningocele. And here, the spinal cord, you can see got tethered to the posterior membrane as such. And you can see even the neuronal elements also here. And this is a large myelomeningocele. Okay. And what do you do, Dr. Gauri?
Thank you, Dr. Rajagopal. I'm just going to stop. Can you stop sharing? I'll just put on my screens. Thank you. That's interesting. So over to the boss who is going to deal with these cases after the baby is born. So Dr. Girish Menon, I want to ask you, like, would you be usually counseling these moms about the possible prognosis and outcome? Because what we don't see the other side of the picture. We only talk about ventriculomegaly, talk about a lot of things, but then you are the person who's going to tell us now what happens to these type of babies and what is your experience, and then can you just give us a snapshot so that in future when we talk to couples we can tell them, well, this is good, this is bad, this is ugly. Please, over to you.
Thanks, Dr. Gauri. Now this lady, she's an elderly lady around 39, but a well-educated lady. So we had an advantage that we could counsel her properly. And unfortunately, she came to us quite late. That's towards the fag end of her term. Although she was diagnosed quite earlier in Dubai, it was too late for any kind of termination or so forth. So what we generally counsel them is these kids have three kinds of problems: urological, orthopedic, and neurological. Neurological in the sense of wasting, weakness of the lower limbs; orthopedic in the form of bony anomalies of genurica ovatum and valgus deformities and so forth. And of course, the most troubling is the urological, the sphincter-related problems of incontinence, double incontinence of both feces and urine. Generally, although the hydrocephalus component and the Chiari component is also associated, the upper story generally remains okay in terms that although the IQ might not reach their peers, they generally do well in terms of learning problems, and the main problem is the quality of life. So survival is not an issue. It is the quality of survival that becomes a problem for all of them. So recently, in fact, Akhila and Rupa might know, we had another baby who came very early. In fact, another educated doctor couple's kid. They were diagnosed, ocular diagnosed quite early, around 15th week. Now, here we had an option of, again, the same counseling was done to them. And now they want to wait and confirm the diagnosis. Now, this is diagnosed quite early at 15th week. And open neural defect has been diagnosed on ultrasound. And she's planned for an amniocentesis and probably an MRI also to reconfirm that. So in this, this again is an elderly primate, in fact, and probably a precious pregnancy for them. But in this case, again, considering the pros and cons and the outlook of the prognosis of this child in terms of quality of life, and because it's really early into her pregnancy, she has other options also. So in the first lady, what we did is we soon after her birth, we repaired the myelomeningocele. And unfortunately, after a few weeks, her head circumference started increasing, and then the baby had to undergo a shunt operation also. Now, this is here where I would like to suggest that suppose the scenario was different and this baby was in, say, Philadelphia or Brazil, for instance, the two countries where fetal neurosurgery is quite popular, and especially I'm sure all of you would be aware of the MOMS trial, the MOMS trial. If this baby had probably undergone fetal neurosurgery, I'm sure this baby would have, if she was in one of those centers, they would have probably she would have undergone a surgery at the timing varies, but what definitely would have helped is they have found that if it is repaired in utero, the chances of hydrocephalus comes down by 40%, the chances of Chiari comes down by almost 60%, and the posterior fossa development, as Rajagopal was showing this, there was a small posterior fossa. So the posterior fossa volume, the incidence of Chiari, and the incidence of chances of hydrocephalus comes down drastically in patients who undergo fetal neurosurgery in utero. Unfortunately for us in India, and we lack the expertise so far. I'm sure in the near future that is going to come.
Thank you, Dr. Girish.
Thanks.
And I think, as you rightly said, management depends on many factors. First of all, a dedicated 11 to 14 week scan combined with a transvaginal ultrasound will help us exclude many of these neurotube abnormalities. And if we see an abnormality, and I think it's good, or if you're not sure of something, always bring the baby, feed a lady at 16 weeks so that we can see things much better. So we have time to maneuver these cases. And then, of course, as you rightly said, the parent should be given all the choices, including counseling and management. And this is always involves a multidisciplinary team involving the neurosurgeon, the obstetrician, and the pediatrician to discuss what happens. And of course, an MRI to assess the endocrine anatomy will also add flavor to this management of this condition. So thank you all, team, for this wonderful input on the first case. We are moving to the next case. Yeah, case 2. Over to you, Rupa or Nivedita, who was here to present. Okay.
So presenting the second case, she was a multigravida. Previously, she had a normal child, and she presented at 36 weeks with the first, what we did when we did an ultrasound, what we saw was cardiac rhabdomyomas, and along with that, we found renal cysts. So we thought there might be, we had a suspicion of tuberous sclerosis during this time. And we tried doing a neurosonography in this patient, but we were not able to. We had a suspicion of some subependymal nodules, but we were not very sure of this diagnosis. And so we had given an option of prenatal MRI for this baby. But since she was close to term, she decided that after the delivery, she would undergo further investigations.
Yeah.
So,
okay.
Yes,
Good.
sir.
So questions to the fetal medicine team, how early can you see cardiac rhabdomyomas, and how good are we at picking up intracranial findings of tuberous sclerosis?
As you can, the CNS involvement is, I think, quite common in tuberous sclerosis. But very often we cannot make a confident diagnosis of cortical tubers and CNS involvement based on ultrasound alone. Of course, sometimes subependymal nodules may be seen. However, you can not rule out or rule in the CNS involvement. So it is much better to go for an MRI, I think, Gauri.
Okay, yeah, you're right actually, and then we will see. Okay, Dr. Rajagopal, would you be able to tell us some of the features of tuberous sclerosis? I'm going to stop sharing here, and you can start sharing your screen now.
Okay. Yeah, this is one of the cases where you can show that the MRI, sometimes it gives too much additional information where you can diagnose the thing very well. So here it's a newborn baby, okay? The newborn baby brain, how it looks is totally different from the adult brain, right? So these are T1 weighted scans. So why I'm telling it looks different is, so the white matter in the adult on T1 weighted scans looks very bright, okay? They were little more grayish, like more whiter areas, the white matter. Whereas in case of the newborn baby, the white matter looks darker because those are unmyelinated fibers. So in this case, what you see is uh, adjacent to the lateral ventricles, the multiple subependymal nodules. Okay, so these on T1 weighted scans, these look as relatively hyperintense nodules. Okay, and even the cortical tubers, for that matter, these are the cortical tubers. What you're seeing here, and because this is a neonatal brain, and these are looking as a hyperintense focus. Okay, multiple hyperintense focus in the cortical and subcortical regions. Okay, these are cortical tubers, and these are subependymal nodules. So whenever you see this, you have to get clearly focus on one particular area. Okay, the foramen of Monroe region, especially if you see the subependymal nodule, if it is enlarging. Okay, so you have to suspect subependymal giant cell astrocytoma also, and those can enhance after giving post contrast. That means after giving gadolinium, it can enhance. So here, essentially, what you're seeing is subependymal multiple nodules and cortical tubers, multiple cortical tubers. Sometimes you can see in the white matter the radial, the migrational lines also. So these are essentially hematomas, what you're seeing, right? These are T1 weighted scan. So when you move on to the T2 weighted scan, so this again looks totally different when compared to the adult brain. So in adult brain, the white matter looks darker, whereas in the neonatal brain, it looks brighter. And these ependymal nodules, subependymal nodules, so they're looking as a darker areas in the T2 weighted scan. And these even cortical tubers, they were well appreciated in the T1 weighted scan. However, you can also see in the T2 weighted scan as a darker, relatively darker areas, the darker foci in the cortical and subcortical region. And these are the flare sequences where you see the pathology best in the adult brain. However, it's not so very well picked up in the neonatal brain. Although you can see the subependymal nodules very well even in the flare sequences. Over to you, Dr. Gauri.
Yeah, thank you. Yeah, Kenny, I'm going to share my screen now. Yeah, thank you. So yeah, that was very good input, Dr. Rajagopal. But however, I think as far as we are aware, in fetal MRI, we use T2 weighted sequences, and that can be technically challenging to use T1 weighted, I believe. And then, and we can see some of these findings, but not as characteristic as you mentioned. But that's good for us to know. And we have a lot of Greek and Latin words, but we have to just, as obstetricians, we have to just make sure we get familiar. So T1 and T2 are the most important things which we have to look at the images. Anyway, moving on, Rupa, over to you.
Yes, sir. So she underwent an emergency LSUS for non-reassuring NST. However, the baby was fine, had good upguards. But what we noticed was baby had that hypomelanotic nodules, Chagrine patches, multiple cardiac rhabdomyomas, renal cysts, and right retinal astrocytoma. Neonatal neurosonnogram, although showed no abnormalities, but MRI, as already shown, showed abnormalities.
I'm going to invite Dr. Leslie Lewis here to just explain us about what are the immediate problems they would face in neonatal, as a neonatal consultant in seeing these babies, or is there any role for antenatal counseling for these patients? Over to you, Dr. Leslie.
Yeah, thank you very much for this very good high-end fetal medicine webinar, and you're all enjoying it, and a lot of message we are getting from this webinar. So we keep getting at least 3 or 4 cases of a tuberous sclerosis every year. And some cases where now, because of the advances in fetal medicine, most of the cases are managed, picked up antenatally. But earlier, we have picked up through mother, where antenatal scans few years back, where antenatal scans were only showing rhabdomyomas, and few rhabdomyomas are not very significant. And then counseling, postnatally counseling with the mothers, we could find out that she is having adenoma sebaceous over the face, and history of a seizure, which is neglected also. And through that, we were able to pick up 2 cases, at least a few years back. But now that is not the scenario. Now we are picking up. Immediate neonatal period, most of these babies they do very good, at least the first a few months of life. What we keep seeing, around 3 months of age to 6 months of age, especially with the multiple CNS tubers, these babies are going to get a seizures, because tubers are a epileptogenic foci in these babies. Initially, to start with, they may have a focal seizures, and then a multiple spectrum of seizures. We have seen a couple of babies going into infantile spasms in the first 6 months of life. Infantile spasms are nothing but they are severe form of seizures, and they are very difficult to control also. And some of those babies are later stage, at the end of a year or 2 years of age, having a refractory seizures. This is what we are seeing related to a seizures or CNS manifestation. A few babies we followed up a little later, beyond 3 years of age. They do develop a lot of neuropsychiatric problems, especially they have a poor intellectual development, especially the school age group children. They do bad with the mass cognition and the part of that, whereas the other skills, social skills, they were very good. So that is related to a neurological manifestation. Cardiac manifestation, we have seen a couple of babies. They do present with one baby had a right ventricular outflow obstruction. And we have to keep monitoring the baby cardiac function over a period of time, because there's a good amount of tubers were sitting in the left ventricle, obstructing their left ventricular outflow. And one baby we presented with the arrhythmias also. There are cases reported with arrhythmias as well as the WPW syndrome, but they are not very commonly we have seen. Renal cyst, we need to monitor these babies, because a first decade of life, these babies going to develop some kind of problems, especially obstructive uropathy and all. And blood pressure monitoring is a routine in these babies, at least once in year, and the renal ultrasound is necessary. This is also, people say, could be a multicystic disease at later stage, or polycystic variant also. We're not very sure about that. So these are the few things, but the CNS manifestations not evident till 3 months of age, and then we see them later.
Thank you, Dr. Leslie. That's a lot more than what we already know, and it's important for us to adequately let the patients aware. And I think it's important to have a very good antenatal counseling to discuss the possible complications we occur postnatally. Just one question, like if we see the tubers, like is there any treatment, like we don't have a cardiac or sick person in the panel, is there any ablation is being done in your experience? Know of anything ablation being done?
No. Most of this, as the baby grows up, as the cardia increases in size, we have seen their left ventricular function or right ventricular function is improving. We never seen any intervention, and these are multiple tubers inside the. It's very difficult to, surgically not possible. I'm not sure about the laser ablation.
Okay, right. Thank you very much, sir. Thank you. I think we already discussed about this. Yeah. So now the next important bit is how to involve in pre-test genetic counseling for future pregnancies. And that is where we need the geneticist here with us, who is going to tell us how these the couples can be managed in the future pregnancies, what tests are available to diagnose these conditions, and all those things. I think, I don't know whether Dr. Girisha is around in the audience.
He is actually in the audience, and unfortunately he could not join us as a faculty.
Right. So
You
can I don't know. I will just have to find out. Let me see. I am scrolling through and see if give me a couple of minutes, because that's going to be vital. His information is going to be useful for us. So I'm just Girisha. Let me just
Mr. Vishal, Mr.
yeah.
Vishal, can you please unmute?
I've got him. Yeah, I've got him. Don't worry. I got him here.
You need to unmute him.
Yeah, I asked him to unmute. Dr. Girisha?
Yeah, I think.
Oh, fantastic!
Yeah.
Oh, nice to see you. Fantastic. We need your input now. Yeah,
no, I was just attending your wonderful webinar. You already have several experts, but
you're icing on the cake now. Please go ahead.
No. But you can see this the case described by Rupa and comments by Rajgopal and Leslie. The diagnosis of tuberous sclerosis is straightforward. When we see multiple tumors, and either in the heart or brain, I think you have a diagnosis. You really do not need genetic testing for confirmation. What I would do next is, as Dr. Leslie has said, I would take a thorough history of the father and the mother, and I would do a thorough clinical examination. There may be one Ashley's macule, just adenoma sebaceum, or just one or two small tumors which might have got unnoticed, because tuberous sclerosis has a very wide phenotypic expressivity. So some may be very mild, some may be very severe. So intellectual disability may or may not be there. So it is usually a clinical diagnosis, and even when you see two tubers in the heart, then you have a diagnosis. If it is only in the baby, whenever possible, I would do a genetic testing. Okay, if it is seen only in the baby, it is likely to be de novo, where we say father and mother do not have this, only child has. Usually, it doesn't recur. Okay, but I would start with somebody who has symptoms, either the baby or the parents, and then offer prenatal diagnosis, because it is not easy to live with this condition, especially if you have epilepsy and intellectual disability. These two are most disturbing. But somebody with just a skin lesion or adenoma sebaceum who doesn't have intellectual disability or seizure, they may not really feel it is really important. So very wide variability of the phenotype, variable expression. Okay, and these things really make complicate. Testing is very simple. You have to test TSP1 and 2 either by sequencing, because deletions and duplications are deletions are common. We need to do MLPA as well. So then we can offer definitive prenatal diagnosis in their subsequent pregnancies, or even
what testing would you
pre-implantation.
offer? Yeah, what test? For example, let us assume this couple is coming for the next pregnancy and they are planning to get pregnant. So they're asking me, Dr. Gauri, you need to tell me what should I do?
I would test the child, and depends on the lab. In Manipal, what we do is we do exome sequencing, because we do not have panels here. Okay, there are two types. The ideal test would be to do a panel, which is hardly available in India. That is one situation. But we have virtual panels where people do exome sequencing and look at only these two genes. If you don't get a mutation, I will do an MLPA for deletion and duplication analysis. So practically, those centers which do not have panels would do exome sequencing, because these are very large genes. Just sequencing these two genes would cost more than exome sequencing. So they are so big. Okay, and mutations are very well known for these two genes. So it should be very easy to get a genetic test done. We do by exome sequencing, but internationally, people would prefer a panel testing, which should work out cheaper. if you are having large number of samples or if they are referral centers. Otherwise, exome sequencing is cheaper in our country.
And what is the turnaround time? Like, for example, if they come at 6 weeks, when should they come for the next pregnancy, do these tests and things like that?
Turnaround time for, see, if we have a diagnosis, genetic diagnosis in the mother, as in this case, or in the baby, then turnaround time is less than 1 week. We don't do exome sequencing for the baby here.
Right.
We identify it first in the first child or parents, then we just do a targeted genetic testing. If it is a point mutation, it just takes 2 days for us to give the.
Fantastic.
So it is important that we have a genetic test done for parents or the first baby, right? So that we can offer prenatal testing at 11 weeks by CVS, and we can give the report in 3 to 4 days.
So just to summarize, this case has got a lot of input. So when we see this, we have to be aware and we have to involve the team, as mentioned before. Always teamwork is good. And then once we know the mutation, the next for the subsequent pregnancy is going to be pretty easy, as what Dr. Girish has said. So we will move on to the next case. Case 3, please. Is Dr. Rupa around?
Hello,
Yeah.
sir, I'm Dr. Nivedita. I'll be
Please.
presenting the case.
Okay.
So, this patient referred to us at 36 weeks of gestation. On ultrasonography, there was large intracranial extraaxial cystic lesion with severe compression over the brain, causing the midline shift, probably arising from subarachnoid or subdural space. Parents wanted to know more about the cyst, so we requested for the fetal MRI. Here in the image, we can see the large cyst causing the midline shift. Next slide.
Yeah. Can I share this?
Yeah, please. I'm just going to stop sharing and then you can share. Thanks, Ram.
Yeah, this is the fetal MRI images. In this case particularly, I mean, whatever the information that you got in the ultrasound almost seems similar findings. So here, what you can see, this is the axial images, and this is the coronal images. Okay, one important, the best aspect of MR is that you can take sections in any plane. So once you get this, you can take sagittal or coronal, dead coronal or oblique coronal or the sagittal sequences very well on MRI. Okay, here what you're seeing is the large CSF signal intensity area in extraaxial in location. Okay, it's not arising from the parenchyma per se. On the right side. Okay, and it's almost a lenticular shape, suggesting that it's possibly subdural in location, right? And totally in all the images you can see that the signal intensity similar to that of CSF, saying that it's a cystic area. Okay, and it's causing significant mass effect on the adjacent brain parenchyma, and even the midline. There is also midline shift, significant midline shift to the opposite side, to the left side, right? And yeah, those were the fetal MRI images, and these are the neonatal after birth. Okay, so almost the information of what was there in the fetal MRI exactly almost similar, even in the neonatal MRI. So here, what you can see almost the same finding in subdural, the fluid collection causing mass effect in the adjacent the brain parenchyma as well as the midline shift to the left side. Okay, and here the differential diagnosis would be possibly, as Nivedita was talking about, the arachnoid cyst. But here we don't think about arachnoid cyst in this case because the mass effect is not like that. Okay, it's almost a lenticular shape. So if it is arachnoid cyst, probably it would have displaced the whole of the brain parenchyma like this. Okay, so unlikely that this is arachnoid cyst. Although this is a differential in this particular case, this most likely the subdural, the fluid collection, or what do you call a subdural hygroma. Okay, this is before doing surgery. There were the large subdural collection here. This is after putting a shunt. Here you can see the shunt tube NC2. There is marginal decrease in the subdural collection here, and even marginal decrease in the even the midline shift also in the post procedure. Okay, the post shunting procedure is this. These are the CT images. These are the MRI images. Okay, what do you, Dr. Gaur?
Yeah, thank you. Yeah. Yeah. So now the question is to Dr. Akila. If there is a big head, the head circumference is big, so would you recommend normal delivery or cesarean section, or what do you how do you look after these babies, and what is the immediate neonatal input you expect from the neonatologist? That will be followed by Dr. Leslie. So once you start, and then Dr. Leslie will follow the case from there.
So as long as the head circumference is well within 40 centimeters, there is no evidence to say that by doing a cesarean section, you're going to change any neurological outcome. So standard obstetric indications should take you through the delivery. But if there is a significant macrocephaly, head circumference more than 40 centimeters, definitely it is better to go for a elective cesarean section in order to avoid any kind of trauma or maybe hemorrhage into the cyst. You will only worsen the situation, isn't it? So I think that is the best call from our side, from the obstetric angle. And over to you, Dr. Leslie.
Yeah, large head is always worrying for us. One end, the resuscitation part. Second thing is a stabilization of this baby. And third thing is whether this baby requires, whether the underlying the large head, whether it is underlying surgical intervention is required. This baby we stabilized. This baby did not require any resuscitation. Baby did not require any ventilator support also. Hemodynamically was stable. And this baby, we have taken opinion from Girish Menon's team, and then a serial monitoring of our head circumference. I think where the day-to-day management definitely gives a clue how early to go for intervention. This is already showing some amount of the compression of the brain, and what we worry is about the ventilation or the breathing part of this baby. Especially the breathing is going to be affected very early. So we need to, and if there's a definitive surgical intervention has to be there, it has to be done very early. So if there is baby's breathing is good, feeding is good, possibly we'll wait for some times, and then we'll take a call from surgical team what they want to do for this baby.
Okay. What are the investigations would you do immediately after the baby is born? Would you just do a standard neurosonogram, or would you do a urgent fetal MRI or neonatal MRI?
We do a neonatal MRI at the earliest within the first 48 hours based on the baby's hemodynamic stability and respiratory status. If it's respiratory stable, we go for a MRI. The baby is respiratory wise unstable, we go for a CT scan. Not a very good modality in this case, but we have no other options, especially such babies, to go for a 1 to 1.5 hours of a MRI. Subjecting this baby will be a difficult one.
Thank you, Dr. Leslie. And Dr. Girish, I think you have enough experience in managing these cases after they're born. Could you share some of your thoughts and how do you see these cases, and what is the overall outcome?
Thank you, Dr. Gauri. Now, this variable term nomenclature for this subdural hygroma, so forth, but they are all under one big umbrella now, merged as external hydrocephalus. In fact, large head with external hydrocephalus, and I must admit that these are usually self-limiting conditions. Now, even in this baby, if you see, I'm not too sure whether shunt really helped the baby. If you see the pre and post shunt scans, the size of the subdural collection remains the same. So generally, there is some abnormality in this CSF absorption mechanism, and there is some drainage obstruction somewhere. The main catch is in these children is to know whether it's an obstructive kind of pathology or it is just whether there's raised intracranial pressure or not. So that is very difficult even with the MRI. As you see in this patient, you feel there is a midline shift because there's a cross collection on one side. And we just did a shunt to give the baby the benefit of doubt in this instance. But generally, external hydrocephalus, usually if this baby was born without a pre-op diagnosis, and if this was picked later, we would be just managing conservatively. They are generally self-limiting problems. Very few of them require shunt, and then even if shunt is done, the post-op scan usually looks the same. It's quite often difficult to distinguish the pre-op and the post-op scan.
You made a very wonderful and a valid point here, because that will preclude us as fetal medicine people to just put some needles into it, hoping to just drain some of the fluid. Because when we see this midline shift, we will get terribly excited to just do something. And I think you rightly said, better don't touch, and that can be managed postally. Thank you. That is wise words of wisdom. Thank you. I think we have finished this. Yes. Okay. Nivedita, are you going to talk about this case? Yeah.
Sir, this was another similar case with posterior cranial fossa cyst, probably arachnoid cyst, but it remained, the size was stable till the time of delivery. This baby is under follow-up now.
Oh, very nice. So that again reiterates the point which we mentioned. So this, as we said in the lecture, we have to monitor this. And usually arachnoid cysts, if they are benign, they don't cause any mass effect, we can just monitor them, and they can be best left postnatally to manage rather than just doing some active intervention. That is one case. That's very good. Thank you. Okay, moving to the fourth case and last case for today. Yeah.
Yes, sir. I'll be presenting a case of lesioncephaly. Next slide, please.
Yeah.
Our patient, she was 23-year-old, gravided to para 1, intrauterine death 1, referred to us at 28 weeks of gestation with non-immune fetal hydrops. Her first pregnancy, she had intrauterine demise at 7 months, and there was fetal hydrops, but that was not evaluated and no information was available. In the current pregnancy, we did a detailed ultrasonography, which showed a multiple abnormality, mostly fitting into a rarer genetic etiology, not common chromosomal abnormality. Next slide. So here in the image, you can see at 28 weeks of gestation, the sulci and gyri are very primitive. They are very shallow, and there is the cortical mantle is thickened, and there is increased in the extracerebral space. And in the second image, you can see the entire corpus callosum, but when we measured the corpus callosum, it was on the 5th centile for the given period of gestation. And also there is interhemispheric cyst is seen. And there is borderline ventriculomegaly on either side, about 14 millimeter. And again, there is a thickening of the cortical mantle, and it is dumbbell shaped. Whole cortex, cerebral cortex is of dumbbell shaped, and increase in the cisterna magna posteriorly. So, so these features may be fitting into classical lesioncephaly with lot of additional morphological information to guide the genetic testing.
Okay.
Next slide.
I think there's some videos coming. Yeah. Good.
Yes, sir.
Fine. Yeah. Okay. You want to talk
So
on
these
this?
were the other extra CNS manifestations. There was mid-phase hypoplasia, and the fist. There was fist. Hands were fisted, and there was also sandal gap. And here you can see the calcification of the lens, and there was hepatomegaly and splenomegaly. These were extra CNS manifestation in this particular baby.
Looks really scary. I think the hydrops was a red herring. I don't know, because there is some other thing, and then it's really interesting to know. Okay, so come over to the fetal medicine specialist, Dr. Akila Vasudeva. We already said it was an autoimmune hydrop. So what do you hope to achieve by doing a chordosynthesis?
So basically, chordosynthesis will guide us closer and closer to the diagnosis, and you can rule out other differential diagnoses one by one. So the first and the foremost is a genetic testing. We sent for qPCR and karyotype, both were normal as expected. There was fetal, so anemia being the one of the important pathway of diagnosis. There was anemia, but it was very clearly, the picture was not due to anemia. So it is not a hydrops due to anemia, because there are so many other problems in this baby. Anemia is only a part of the overall picture. There was anemia, there was thrombocytopenia, leukopenia. So that means there is pancytopenia. Liver enzymes were raised. AST was some 900, ALT was 600 in this baby. There was severe hypoproteinemia, DCT was negative. We also sent PCR from the fetal blood parvo and CMV were negative. Fetal karyotype was normal. So we did discuss this case with medical geneticists. So we have Dr. Girish. So the ultrasound things were all discussed with the geneticist. But the real scenario, as usual in India, what happens after this? After all this, patient went outside and at about 30 weeks, they call it termination. I don't know how to call that. So despite extensive counseling on the need of a thorough workup, patient never turned up. She got the pregnancy so-called terminated outside without any autopsy, perinatal pathology examination. They have not come back for a counseling on further genetic workup. In fact, this is the second affected pregnancy for her. And unfortunately, we were not able to give a pinpoint diagnosis.
Are they consanguineous, by the way?
Yeah,
Non-consanguineous.
consanguineous.
They're
Yes.
consanguineous. Okay, so I think here the role of a geneticist is really valuable, and I think let us imagine this scenario, like if they are up for genetic workup, so how will these things take further? Like, is Dr. Girish around?
Yeah, Gauri.
Good. So imagine, Dr. Girish, that this couple want to do some genetic testing and want to know the grassroots of the problem. How do we help this couple?
Yeah.
Because there's a second baby, they're lost.
Yeah, we had an internal discussion with the Akila's team here in Manipal. We see from the current scenario, we would do an exome sequencing for this family, just to be sure this is not chromosomal, very less likely to be chromosomal or infection. We might do a microarray, but now it is okay to directly go with the exome sequencing because 2 fetuses were affected, and that means it is likely to be a recessive condition. And we have at least, I was just going through before this webinar, we have at least 16 listed lissencephaly genes. Okay, so there are probably more than that. Some are discovered, some are new, and I would do an exome sequencing from whatever sample we have. This is a situation I would say, let us keep some amniotic fluid sample or CVS sample or cord blood sample. Even if a neonatologist sees, take some sample and keep. We had situations where people carried dried umbilical cord to us, and we did exome sequencing from dried umbilical cord stump because once I was asking a family, do you have any sample? Then the lady opened her purse and said, this is my baby. Actually, she was carrying the cord stump. So anything of that kind should be traced, and we should do. Sometimes some newborn screening must have been sent to some lab. So if we trace, that would be great. So here, I think whole exome sequencing would establish a diagnosis of lissencephaly whenever we do. But I think last few years we have been seeing rapid advances in genetic testing. Probably the best one is NIPS, non-invasive prenatal screening. So soon, fetal medicine centers are going to have NGS machine, including ours. So we offer this kind of testing prenatally before 20 weeks, so that they don't have to run here and there, and we diagnose before 20 weeks and offer prenatal testing. That is ultimate wish. I think the testing should be very straightforward by exome sequencing.
Thank you. Just out of question, do you have any panel for this hydrops? Do you have any panel at all?
Yeah. So I noticed that this is an excellent question, because I think we are having around 150 to 200 people attending this seminar. I would want to tell what is a panel. Okay, panel is nothing but you take genes which cause or which are responsible for a particular condition. It may be lissencephaly, it may be hydrospitalis. Okay, so panel is a smaller number of genes, and the baits are put for only smaller number of genes, and then they are captured and sequenced. Exome is all the genes. Okay, so exome kits are readily available everywhere, and they are very cheap now because of the competition used, because it is used everywhere. Okay, so panels are not, but panels, if given a choice, I would do a panel, provided that I have regular referrals for this kind of diseases, and it will be cheaper. But the problem with the panel is it has to be updated every 6 months or every year, because now we get one lissencephaly gene every other month, one hydrospitalis gene every 3 months. Okay, so your panel gets outdated. Okay, so and then there is something called virtual panel. People don't use this virtual often in their catalog list of test catalog. I will not name the company X, Y, Z. Most of the people do virtual panel. What they do exome sequencing and look at only hydrops fetalis gene or listen separate gene. Actually, this is not a panel. Okay,
Right.
so there may be some gaps which the lab should be careful. The clinician should know. So I think it is okay to do an exome in India as long as you use the virtual panel, and if you don't get a diagnosis, please expand because you have the data of all 20,000 genes.
Right.
Okay, so you already have the data. Virtual panel is only looking at the selected gene.
Okay.
And you can just remove those filters and say that all the genes I need to see. So that is okay. But if you really have a panel of genes and a special capture kit for them, then that is probably the best thing to do.
Thank you very much, Girish. So that is, thanks for clarifying this,
Yeah.
because these are the technical we say the finer blueprint, which we are not very familiar with. And then that is very important for us to know. And thank you for that. And first of all, I would like to thank all my panelists. So as I said earlier, you heard straight from the horse's mouth. So you got the best of the information from the experts. So now you know what to do in these situations. So just to conclude, I say the outcome depends on an underlying etiology. Fetal MRI complements ultrasound in diagnosis and prognosis in some conditions in brain abnormalities. The key is always a multidisciplinary team. Always share your responsibility. Don't say that it's we, so that we can involve. Because now in this meeting, we have learned a lot than what we already know. So that's important to have a panel or a team where we can discuss these cases because CNS always has a various complex clinical presentation. And it's very, very vital to know we have adequate pre-pregnancy counseling, essential for future pregnancies. And I always put the slide, a team is always not one, but many hands to form one brain, okay? And with this, I conclude this lecture discussion, and I hope you all enjoyed it. And I thank the panelists once again for staying with me and taking all the questions and answering it. Thank you one and all. Have a very good evening.
If I can just add one sentence here, Dr. Khurana, a special thanks to Dr. Girish. He, because of his personal commitments, he could not join as a faculty, but still he came around as an audience, and and he contributed to the betterment of knowledge. Thank you so much, Dr. Girish. Thank you so much.
Yes, it is fantastic inputs and truly a fabulous panel. It's been very enlightening, and as Dr. Chinmay Rath has put in, she's one of our senior members. She says the positive thing about such good work is that we will know what exactly is the eildogenetic test in these cases, and we can optimize the requisitions in settings that are less resource endowed, which I think is the essence of what we're trying to do. And we also have a great message of appreciation from Professor Pratap Kumar. For people in Society for Fetal Medicine who don't know him, he's Chief of Reproductive Medicine at Manipal. And he mentioned that it's an excellent program by the Manipal team, and he is so proud of them. And he agrees that this is a very, very high-class webinar, and he's actually been listening to all of this, which I think is fantastic. Somebody from outside the field sitting and listening to us speaks volumes for the effort put in today. And I'd really like to thank each one of you, and Akhila especially, for putting together such a fascinating program. We do put together some of our programs onto our SFM YouTube channel, and you can all watch them there. But I would encourage you also, for those of you who are not members, to become members and contact us either through the website or directly, and we'd be so happy to have you all in the family. Thank you indeed, and my thanks to the whole team. My thanks to Vishal Mittal in our back office, as well as to Conferences International for all their technical support for the webinar. It's been a pleasure this evening. Thank you, each one of you.
Thank you very much, sir. Thank you very much for the opportunity.
Thank you, Professor Khurana. It's a fantastic evening. Thank you. Thank you.
Thanks, Gauri. This is wonderful. Thanks a lot. Good night.
Good night.
Good night. Good night.